It is September 18th, 2025 at 9:04 a.m. The board meeting of the Oregon State Board of Nursing is now called to order. A notice of this board meeting was published by Rachel Prusak, Executive Director, in accordance with the open meeting law. If necessary, the board may also meet in executive session as authorized by ORS 192.6601, ORS 192.6602 F and L, ORS 678.126, ORS 676.165, and ORS 676.1751. Board members and staff stating that they are present are attesting to understanding the confidentiality of executive session and have taken steps to ensure that the executive session proceedings are not observed or heard by anyone not authorized by Public Meetings Law, ORS 192.660. Is there a roll call by our secretary?
Yes. Marcus Cooksey.
Present.
Margaret Hill. Present. Claire McKinley-Yoder, present. Joni Callis.
Here.
Linda Stanich. Present. Oleniki Toabola.
Present.
Rachel Dennis.
Here.
Felipa Nesta.
Here.
Rachel Mitzel.
Here.
There being a quorum present, I declare this board eligible to conduct its business. Would the executive director like to do it?
Good morning, everyone. I am going to turn to our virtual attendees to kick us off. I see License Manager Philip Fox.
Present.
Fiscal Manager John Etherington.
Present.
Good. Policy Analyst Amanda. Great. And I do know that we will have our investigations manager and support manager joining us in a little bit, probably in an hour or so. And then starting over with our policy analyst down at this end, just please announce yourself that you're present.
Hey, Gretchen Cook.
Sarah Wickenhagen.
Laura Blackhurst.
Lauren Rauch, Legal Counsel.
Kimberly Goddard.
And Rachel Prusak, Executive Director. We're here. We're ready to go.
Executive session. Presentation. It is the Oregon State Board of Nursing will now meet in executive session to consider advice from legal counsel, which is exempt from public inspection. This executive session is held in pursuant to ORS 192.6601 and ORS 192.6602 F. Audience. Members of the news media may remain during executive session but are directed not to report on, record, or otherwise disclose any of the deliberations or information discussed during the executive session. If you are a member of the public, please note that the public video stream will be unavailable during executive session. No final action will take place in executive session. At the end of the executive session, the board will return to public session for the purpose of taking formal action on matters discussed in executive session. While the board is in public session, the public video stream will be available. It is estimated that the executive session will end at 10 a.m. It is 10:02 a.m. and the board will now exit executive session. I was thinking, yeah.
No. For the 5 minutes.
I can public session us and then we'll take a break. Okay. It is, no, I haven't, it is 10:03 a.m. and the board will now meet in public session for the purpose of taking formal action on matters discussed in executive. No, sorry. We're on a 5-minute break right now. Ignore what I just said. have a slight change to our schedule. Well, we're going to start on time for our panel. We're 2 minutes late. That has graciously given their time to present to us. And I'd like to, I see that we have a few folks online. We're going to turn first to the people that have come here in person, and then we'll shift to the folks online. So for our guests that are here in person, I'd ask that you sit up here in the front. The mics are currently off. That's the red light. So just press it once and it will green light you to be able to talk so that everyone online can hear.
We can share a mic. Yeah.
And so please, give us an introduction first off. And who you are.
My name is Allison Rudisell. I am the clinical nurse educator here at Adventist Health Potomac.
And how long have you been here?
Oh, I've been with Adventist Health for over a decade. But I've only been in the clinical education role for 6 months, something like that.
I'm Heather Thompson. I'm the CNO. We call it patient care executive here. I have been with Adventist Health for 25 years, just in September this month. And I've been in this role since for 3.5 years. So it's been lots of fun things here at Adventist Health. You get to grow and learn and do lots of stuff. So Allison also is or was the main clinical educator at the local community college. And so that's kind of what we're here to talk about as well, about our partnership and how that has been evolving over the last few years.
Yeah, so I've taught clinicals before with Concordia, and then got away from that for a few years, and then TBCC opened their nursing program, and I was very excited because it's in my community. So I started doing clinical rotations with them, and then when I took over this role, I've essentially been kind of like a liaison between both, because I'm still teaching clinicals with TBCC, but I'm also the clinical educator here. So it's been this nice bridge so that we can coordinate and make it a seamless transition to the students from their, their lectures and didactic to their clinical rotations. So it's been really lovely.
And we had reached out to our local community college several years ago with a nursing shortage, asking if they would be able to develop a program. And it's a struggle to start something from the ground up. I mean, there's just a lot that you don't know. And being really closely partnered with them, the community came together as well and agreed to support a bond measure for their continued program and to create a whole new occupation, or what is it, health? Anyway, a huge campus for them to be able to do more than just, yeah. So it's been really great, the community support as well as the hospital support and the staffing. And, we have a lot of people that want to remain in the community, and to have the ability to have a program like that is just outstanding. So I don't know what other kind of questions that you guys have on that.
Yeah, so just as a reminder for all the board members, when we were in Southern Oregon, we invited the hospitals and how they, the hospitals and the education systems and how they partner to really address this topic of clinical placements that we hear about all of the time. And so this is an opportunity to ask questions about those that are doing it on the coast. And we will have somebody else join us as well after for another example.
So how many students do you guys accept each? Is it just once a year, or do you have a rolling admission?
Yeah, so they're doing, it's one cohort a year. And let's see, this last cohort was 28 students, I believe, started out with. And then we do, I can't have more than 8 students per clinical rotation at a time. So we'll do a couple days a week usually so that we can get the whole cohort in. What we started doing this last term was just to kind of dip their toe in during their second term. They do kind of like a mini clinical rotation. So for half their term, we have one half of them, and then half the term we have the other half of them, and then the other half is doing sim lab at that time. So they're not doing a lot of clinical skills during that first thing. They're just kind of like learning the layout of the hospital, more like CNA type skills, that kind of thing, getting their confidence level up just with talking with patients, because I feel like that's a major barrier to like students who have not had any clinical background, right? Just walking in that room and saying hi to the patient is terrifying if you're not used to it. So getting them comfortable with that before we're asking them to do, you know, more advanced skills. And I think that really it helped foster this this curiosity, this willingness to jump in, to ask the questions. So I think it's been a great transition for them.
Some of the other things that we've done with clinical rotations, because we are small, we're a 25-bed critical access hospital. Our census on med-surg runs between 8 and 10, so you can't really overwhelm one department. So we have an infusion and oncology center, so we have students do rotations through that where they get to, you know, access ports, work with different providers in kind of a hospital-based clinic that's, you know, pretty acute patients through that as well, oncology patients. We've also had them do some time with our care coordinators in the clinic to kind of get an idea of what the community nursing system looks like here in Tillamook County, as well, of course, emergency room, OB, and surgery. But just knowing that we have a lot of students for a small hospital, it was kind of a little bit stressful, to be honest, when they said, you're going to have 16 students for students. And I was like, what? I don't have that many patients. So really coming up with some great ideas of how to make these experiences really robust for them, and also give them an idea of there's a lot of avenues within nursing, not just acute care. So,
yeah. And I think that's one of the things that's great about critical access is, you know, you're not just stuck on med-surg your whole clinical rotation, right? You get to see all these different pieces. So it's really, I feel like it's a more well-rounded education for them. And it's really kind of fun to see, like, you get a student in to, like, I had one who was terrified of OB, and she spent a day in OB, and she said, you know what? I love it. So, you know, just giving those opportunities to where they can really find what they're passionate about and what they want to go into for nursing is great.
So all your students do all their clinicals within your system here in Tillamook?
Yes. Well, they do, I think they're doing and I can't speak a lot to this piece because I don't do those clinicals, but they do some with the Nehalem Valley Care Center as well.
And also, I believe they're partnering a little bit as well with the health department for some public health and outpatient things there. But the majority of their time is spent here. So we really want to make sure they have a lot of experiences so that they're well-rounded when they graduate.
Do they get to spend time with the therapy staff, inpatient or outpatient? Oh, come on.
That's a great question. They are not currently partnered with them. However, since we have inpatient therapy that is on the med-surg floor and sees those patients, they are interacting with them. But it is definitely something interesting to think about and consider about those relationships as well. So.
Yeah, I do encourage the students, like when they have a patient, like maybe it's total joint or whatever, I said, you know, physical therapy, they're really like an occupational therapy. They're the experts on this stuff. So if you get a chance to watch their assessment, watch how they, you know, work with the patient, I said, do it. Any opportunity you have to do that, because they're going to be the experts on how these patients need to move and restrictions and all of that stuff. So I do encourage that piece, even though it's not like a formal like PTOT rotation.
Are you offering weekend clinical hours?
We did have a weekend clinical rotation. I want to say it was a few terms ago. We did Sundays. The students actually prefer weekday rotations just because there's fewer opportunities here on the weekends. Like surgery is closed. It's just, you know, it's if there's an emergency, right? So, and our outpatient services is closed, that kind of thing. So they really get more opportunities if they come during the week.
So are the bulk of your students full-time then versus working individuals?
No, a lot of them work as well. Yeah.
And they still prefer the weekday.
Yep. That's what I've found.
I have a couple of them that are CNAs currently that are going through the program right now. So we offer tuition reimbursement, so that's really amazing to get them to, progress into different careers. And like, actually, there's one working today, and she was just talking to me about her reimbursement. But so then she's able to pick up either whatever shifts are open outside of her clinicals. So at least for her and my other CNAs, that works well for them because there's always shifts open. There's always CNA needs.
And also, like, as a tourist community, bulk of the shifts for, like, even like at the cheese factory and that kind of, like, weekends are really like when they're trying to bulk up on staff anyways. So that's usually when those students can get the hours for their jobs.
So it really is a geographic thing, because when we were in Southern Oregon, they found that offering weekend clinicals was really valuable.
Oh, interesting.
Yeah, like I said, we did a Sunday rotation, and it was the students. I mean, they got some experience, but it was a little bit of a grumble about that. So we haven't done it since.
Well, and I think to clarify just a little bit, what happened was they were wanting to add more students and needed to get creative with the staff, and the staff agreed to it. And so then therefore they were able to take the students and provide the support, which worked really well. And that's what's so great about, I feel like, the collaborations that we're seeing, the partnerships that we're seeing in the rural areas.
I have two parts. So thank you for being here. But do you guys hire new grads outside of this? And then since we are in such a shortage, at that point, do you then offer education like reimbursement or programs such as like an LPN to RN and help pay for that? Does this facility do that?
A couple things. Yes, we do take new grad residents outside of this program because we also have a community college to the north of us, Clatsop. They don't tend to have students down here anymore, but we have people that live here that went to that school. So I hired 4 new grad residents this year. 3 of them were from the TBCC program, and 1 of them was from that program. As far as tuition reimbursement for LPN to RN, yes, we would. However, I don't really have, I don't know if the school is offering an LPN to RN
Not that I'm aware
program. So I think logistically, I don't think that there's a place that's close that could do that, but yes, we would offer that, just like we offer from CNA to RN, and also, ADN to BSN and further to continue your education. So
Very nice.
We have LPNs in our program, but it's not like an LPN to RN program. So it's not, they're going through the same program as everybody else.
Okay, just curious about the education part of it.
And board member Nesta, the interesting thing about this program, as it was mentioned, it was new. Policy analyst Laura Blackhurst will be going to the school for that kind of beginning survey in November. And so it is something, if the school is looking to do something like that, there'll be conversation and approval.
Very nice. How much of your clinical experience is using simulation?
Like the time that I have them, almost none. They do sim lab at the college. They get signed off on particular skills and stuff before they come to clinicals. I mean, like I said, we did that kind of, dip your toe in like in their second term. But after that, they, well, actually during that term, that second term, they're also, half of them is doing sim lab, half of them is doing that, dip your toe in the clinicals. So during that sim lab time is when they're getting signed off on those particular skills. And then we practice skills here, like with actual patients.
Yeah, and for clarification, Dean Tiffany Slover couldn't join us, so only the hospital section of the collaboration could join us today, but thankfully you were able to give some context to it. But we can find that out in November. They're using that.
They've got amazing sim lab that's opening soon. So very exciting.
It's been a couple of years since I've been out here in Tillamook, and I forgot how beautiful it actually is. So that's compliments to you all. is there an opportunity, and I don't know because when I come out here, it is to Cheesecake or to the ocean, but is there opportunity for them to see either hospice, senior community living also in their rotation, or no?
The Halem Valley Care Center is it's a skilled nursing facility, so they are doing rotations there as well. Hospice, I feel like that's been in discussion. I don't know. Do you know if they've done anything with hospice?
I don't know. However, I do know in speaking with the hospice manager 2 weeks ago that they hired one of the new grads from the program. So they must have done some type of rotation through there. Otherwise, that would be how would you even know that you wanted to do that? So they must be somehow partnering with them. I'm just not aware, because hospice and home health actually is even though it's part of Adventist, it's separate from the hospital part. So we do work with them. They attend like our morning meetings and they're very involved, but I don't know how they do students or anything, unfortunately. But yeah, I was pretty surprised because I was like, oh, I wouldn't have thought that a new grad would have that kind of passion,
Yeah.
So it's amazing. That's a passion to do that job.
It takes a special person.
It does. It's, as I've matured, I feel like I would be better than I would have been as a new grad trying to step into that world where I have some understanding and more ability to have empathy, honestly, that I probably did in my early 20s. And so life experience, I guess, of things.
I was simply going to thank them for
that's what I was going to do was, first of all,
Oh, no, I said 28 students. That's 28 of my students. It's separate cohorts, so I apologize. It's 14 per cohort. So I just wanted to correct that. Sorry about that. So 14 per cohort. I 28.
That sounds much more manageable.
Sorry about that. I was like, as I was thinking, I'm like, I don't think that's what I meant. So sorry.
In addition to thanking the two of you for your time and coming out and checking in on your wonderful program and your ability to partner with the community college, I just wanted to recognize Adventist for providing the space and Tillamook for the natural beauty we're getting to enjoy for our board meeting.
Hopefully you get to go to the beach at some point, maybe. If your toes in the cold water, don't go swimming.
Yeah, no.
A little chilly. But, well, thank you guys. Anything?
Yeah, and please just spread the word to anyone when they're taking a break or walking around to join us. The room is set up a little interesting that they'll have to walk through, but to feel comfortable doing that. Okay. Thank you so much.
And I thank you to our online guests, Dr. Mattis and Dean Cooper, for waiting patiently and being right at the ready, it looks like, to present a little bit about your program and talk to us there. So I'll turn to who's at the top. It's Dean Maddox first, if you want to introduce yourself, and then and you guys can go for your presentation there. You're still muted, please. And
thank you. I'm actually gonna. I'm not the dean. Actually, I'm over at the hospital. My name's Sandra Maddox, and I am responsible for all of the students that come through the hospital and also for our new graduate program that we kind of is an impetus for us to really develop the relationship. But I'll turn it over to the real dean, who is Elizabeth Cooper.
Hi, I'm Elizabeth Cooper. I'm the Dean of Nursing and Allied Health at Southwestern Oregon Community College. Thank you for having us here. I actually was part-time clinical lab instructor for SWOC for 4 years, and then I was a full-time faculty for 4 years, and this is my 3rd year of being the dean over the nursing program. And so we kind of wanted to just kind of start out just to talk about how we really came to develop this strong relationship with Bay Area and a lot of our smaller hospitals in the area. I feel like SWOC has been very fortunate because of where we're located. We have Bay Area, which is our main clinical site, but we also have 3 or 4 critical access hospitals around us within a 20-mile radius. We have Coquille Valley Hospital, Lower Umpqua, and Southern Coos. The other thing that's kind of unique too is that we have another campus down in Brookings that we usually have like 5 to 6 nursing students per cohort down there. Where Curry General Hospital in Gold Beach, that's where those students go for clinicals. And so it's been really important for us to really develop those relationships with all of these hospitals. And so one of the things that I really focused on when I became the administrator was developing that relationship with all of them. I've always believed in all of my leadership roles is that you really have to connect with others and build that relationship so that we can both work together towards our goals and our vision. And so one of the things that really helped out was Sandy reaching out to me and really starting those meetings to talk about the how clinicals have been going in the past, and she's going to kind of talk about those issues that came up when, and then what are the challenges and how can we work together to make sure that the students get the quality education and learning experiences they need to be successful and be able to still meet the needs of the hospitals. And so it feels like every year that we have gone through this process, we've improved on things and it gets smoother and smoother every year. And it just feels like we've gotten to the point now where we've developed that relationship that we feel comfortable when things come up on each other's end to be able to open up and say, hey, can we have a meeting? Let's discuss it. Let's work through the problems and come up with a solution that meets both our area needs. One of the things that we've really worked on is just working on those processes, making sure that the communication for her nursing staff is consistent with what we're relaying to our clinical instructors and the expectations to the students, and just making the onboarding a lot smoother for both us and the hospitals.
I thought maybe I would talk just a little bit about the triggers that really came forward, because I think this is probably, some of these problems are probably true for a lot of hospitals who are hosting students. And the first one really was the chaos that we were having on the units because we didn't have any rules. So we had nursing students everywhere in the hospital, and we're 129 beds. Sometimes we had more nursing students on a unit than we actually had patients. So we were careful about moving forward, being sensitive to the number of people at any one time on a unit. And so I reached out and we had a conversation about limiting that to 4 students, both first and second years, because we have around 47 students that they're here today, by the way. They're on orientation upstairs. So there's a lot of folks that are around. So we limited it to 4 students per unit. And what that really forced Liz to do is kind of look at how she laid out those clinicals. So we have students here in the day shift, on the evening shift, and on the weekend so that we can kind of spread them out and that they all are getting the right interaction with patients. So that was a problem solving that really worked well for us. The next was that we had an issue with a narcotic. Now, it wasn't a true diversion. It was that the student went into the Pyxis and somehow we lost the narcotic. I don't even know exactly remember the issue, but I think it landed underneath the Pyxis or something like that. Eventually we found it. But it forced us to have a conversation with the pharmacy director in our investigation. And he said, I come from out of state, because he was a temp with us at the time. And he said, in the other states that I'm licensed in, we don't let students have access to Pyxis. We only let licensed folks have access to Pyxis. And that was a big aha to us, and we said, that's a smart move. So clearly, we now have the instructors, of course, have access to Pyxis, and then our staff have access to Pyxis, but we do not give that access to our nursing students. They can still learn about the 5 rights. They can give medicine with their instructor, but they just are not independent at the Pyxis, and that's safety for us. That's safety for the school, safety for patients. And the next was that we had 200 charts that were sitting out there without any co-signatures. It was hard for us to figure out who should have co-signed on the nursing student note. And so I had a conversation with Liz about this, about how are we going to move forward so that she understood that we'll allow documentation in the electronic health record, but it has to be only with the person that is set up to co-sign with that student. So let's just say they were on a medical unit. They could co-sign with their instructor, but if they floated to OB or somewhere else that was kind of unexpected, that we'd still like them to float and get that experience, they were not going to chart. And Liz also has in the school a simulation that I'll let her really talk about because I'm not really that familiar with, but I think it's really kind of the cutting edge, called DocuCare, which is a simulation for them to document. So we're not actually putting those students in the electronic health record. We haven't completely gone there, but she has introduced it in her clinicals or her labs at school and beginning to kind of introduce that in our clinical arena. And I just think that's kind of cutting edge. But I agree with her in that those are kind of the key things that kind of force us to kind of get together and problem solve. Of course, we have little things now and then that come up. Maybe one of our students ends up in an incident report. I never do those independent of Liz. I always involve her in that. And so any investigations that we're doing with the students, Liz is part of that whole process. So we spend every quarter that we're getting ready to bring students in 2 months in advance, kind of sitting in and saying who's coming, what are their names. We get them into our systems. We talk about who are going to be the instructor oversight. We share that data with all of our leaders here at the hospital so that they too know who is the instructor, who should I be contacting if there's some kind of issue. So that's really the kind of the key things that have forced us to build this little stronger relationship.
The other thing that the nursing program has done, because as Sandy has mentioned, is that trying to control how many students are in the different units and not overwhelming Bay Area is that's why I mentioned early on is that we have these other smaller hospitals in the area that we send clinical groups out to. And I have a process where I rotate out the students out to these critical access hospitals. We rotate them out into the community realm, like home health and hospice, to pediatric clinic, and to advanced health, which is a managed care Oregon Health Plan organization. And I feel strongly that giving all those students those opportunities to compare critical access hospital to Bay Area size hospital gives them more of a vision of the different types of care, different size hospitals are exposed to, the type of nursing in those areas, and then just understanding those community realms. We're looking to expand that so that they have a more well-rounded perspective around nursing, around different patient populations. Because no matter where they go for nursing, having exposure to the pediatric clinic or home health, even with the managed care at Advanced Health, all will bring them tools for their toolbox and no matter what nursing realm they go into. And so we just feel like that provides them with a robust learning experience and helps with making sure that we're not overwhelming the hospital systems. We also for the first years, their first term, they're out in the skilled facilities. We started that a couple of years ago, just because the skilled nursing facilities can provide the students with just that opportunity to work on their basic nursing care, especially those students that have never touched a patient. And it's been really exciting to see is all of these community nursing realms, the hospitals, all of them have been very supportive of SWOC and the nursing program, and I feel like these relationships have really enhanced the opportunities and learning for the students.
Thank you. Thank you so much for that overview, and kind of, I like the anecdotes too. Those are always fun. I'll ask a question, then I'll turn to the other board members. For those of us that have precepted nurses before, we've experienced that balance between work and help that precepting students is. And I'm wondering, maybe this is more appropriate for Dr. Maddox, like, how do you make that pitch to other nursing leaders or people that are skeptical about taking on precepting nurses?
Oh, that's not a problem here. And I'll tell you why, and that is because we pay them to do it. We don't pay them to do it always, but we definitely do it in our senior practicum, and our nursing folks love doing it. It's never been a problem for me to find a preceptor, because we're good to them. When they do it, we pay them.
Are you finding that through, and I'm not sure, might be
It's okay, we'll filter it.
which one of you, with your clinicals and all of that, are you finding that the students, when they graduate, are they staying local? Are they finding placements with the organizations that they've done clinicals at?
Yeah, about 95% of our students stay local.
I had 33 new grads last year. I have, we're in a little bit of financial turn back right now. We're kind of downsizing our staff and making some changes internally. So we limited to only 13 that came in this time. I'll take some more in the winter around January or February, but we hire a lot of those SWOC students. So we're invested in their success and the knowledge that those students have, because they will come and work for us at Bay Area Hospital. It's a very symbiotic relationship.
I know that with like Curry General, with our 6 graduates down in Brookings, all of them usually get hired by Curry General when they're done with their program. Most of the hospitals in, Bay Area, Coke Hill Valley Hospital, Curry General, they all have loans that they provide to their employees to continue on education to become RNs. I know that Curry General just implemented a program where they're offering incentives for their RNs to go back for their BSN. So all of the hospitals here locally are very supportive of continuing education for nurses, and it's a great thing.
Thank you. So you really are providing a vital service to your community.
Absolutely.
Mm-hmm.
And if it would be okay, Board President, I'd love to invite Paul Sanos, Laura Blackhurst to speak, because it was how I knew to reach out to Sandra Maddox and Elizabeth Cooper because of her experience with a survey. And then, of course, we were going to be in Tillamook at the institution, so reached out to them, but would love to hear her experience there, if that's okay.
Yeah, I had the opportunity to survey Southwest Oregon Community College. I believe it was in March. It's been a while. And as part of that survey, had the opportunity to meet Dr. Maddox and do a tour of Bay Area Hospital. And so just from our perspective in evaluating the nursing program, I was very impressed at what I was seeing and the collaboration between the school and the hospital, just how supportive it was. And I think, again, how much intentionality there was with, what are students doing, what experiences are they having. And I think one of the most interesting things is as I, walked around the hospital, so many of the nurses were graduates of Southwest Oregon Community College, and they were very excited to expound about the program and the collaboration. And so you could really see it on the floor.
So the end degree in your program is an associate's degree in nursing?
Yes.
Do many of your graduates go on and obtain their bachelor's? And if so, through what route?
Yeah, we usually get, just in the past 2 or 3 years, I know that there's been an increase in the number of our students who go on to get their BSN. I would say out of the 46 to 48 graduates we have had each year, maybe half of them go back to get their BSN, and they're going through, most of them go through Oregon Health Science University because, and part of that's because we're a part of OCNE, the Oregon Consortium for Nurse Educators, so that they have that smooth transition over to the RN to BSN with Oregon Health Science.
Internally, we also promote them to move on as part of, the new graduate program and kind of talk to them about career development. Many folks who aren't, there's a lot of people in the community who don't have access really for a BSN and for clinical sites. So it's I feel my responsibility to make sure that we provide some of those clinical opportunities for. I have someone coming from rural Roseburg who's coming over because she couldn't get a clinical site. So we serve a lot of students, not just Liz's group, but the majority of them definitely are from Liz's group, and we have a really good movement of people moving into their bachelor's. They're a little sensitive about it at first because they just want to get out and work, but they come back to me saying thank you for pushing us. So we definitely promote it.
Thank you for all the great work you guys are doing. Second question is, how much of the clinical experience is in the sim lab? If you were going to...
Not very much, very little. That's the thing that we've been fortunate enough, even through COVID, is that we have such strong relationship with all of the hospitals in our community that we didn't have to utilize very much simulation. And so most, I would say maybe 5% is simulation. Most of it's in the clinical settings.
They have a really beautiful sim lab, though, that actually the hospital helped fund. So they let us come over and use it every once in a while for that reason. But she has a beautiful sim lab that you use regularly. You use it always for your students, but you didn't use it for all of your clinicals.
Right. We use it for lab, but we don't use it for clinical replacement.
I think one of the things that this just brought up, since there was some silence, is you know, when I first arrived, the first presenters I had come in was the group of community colleges that fought to, at the legislative level, to have their community colleges be able to allow for bachelors. And of course, that's not us. We're pre-licensure. That's HEC. But now, 2 years later, some of them are in the process of this, and we can I can invite them back to speak to it at some point soon. See where things are at.
Well, thanks to you both for giving your time today to present to us and for us to hear about your wonderful partnership. And we wish you success in continuing it in the evolution.
And
Great.
thank you.
Thank you. Have a good one.
All right. So I would like right now for us to, I'll review the meeting agenda. Don't worry, we'll take I want to change things a little bit. Just that I want to use this time right now to go over the consent agenda and the approving of the board meeting minutes, so we can get that done, and then we could take a break before we move
Recording in progress.
before we move into the administrative rulemaking section. Are there any other changes for the agenda for today?
The only other thing that has been mentioned to me was that Board Member Hill would like to speak to, and I would like to hear it, and I should have added it, her experience at National Council State Board of Nursing Conference, and if Paul Samuels Blackhurst wants to speak to it, of just kind of high-level points they heard and wanted the board to know about, if that's okay with you. I forgot to ask and add.
When do we think that would be a good?
Oh, and it will probably just be a few minutes, so it can be any time you want to add it.
Or we could do it right now. I think we'll move really quickly through the consent agenda. Could do it. I mean, how long are you thinking? Like 5-10 minutes?
I wasn't prepared.
Probably 5.
Well, you've got a few minutes to. Well, we could also do it right after lunch, maybe.
Let's do that.
Okay, right after lunch then. After Jane is speaking at our lunch piece. Perfect. All right, so moving to the consent, unless there's anything else that we wanted agenda-wise. Move to a motion to approve the consent agenda items.
Who's going to make the motion? You want, does one of us make it?
Usually, but I can do it. You know. I don't have the script here. Okay. I'd like to. Yeah, usually staff will do a motion for the consent agenda, but.
I'm sorry, what?
Who's going to make the motions for the?
I'm sorry, I was distracted by our legal counsel, but yes, I will. Uh-huh.
So on page 6, we have the approval of the consent agenda. At least page 6.
Yes, Mr. Board President,
And then-
I would make a motion that the board approves the consent agenda, meeting minutes.
as
moved.
presented.
Second.
It's been moved and seconded. We'll do a roll call. Marcus Cooksey,
Aye.
Margaret Hill,
Aye.
Claire McKinley Yoder, aye. Joni Callis,
Aye.
Linda Stanich,
Aye.
Oleniki Tolobola,
Aye.
Felipa Nesta,
Aye.
Rachel Dennis,
Aye.
Rachel Mitzel.
Aye.
Motion is passed.
Great. And then, were there any edits or adjustments to the meeting minutes from the June meeting and the August meeting? No, looks like not. So,
Is there a motion?
yeah, if we can do a motion for each of them individually,
Each of what individually?
so the meeting minutes, the 2 meetings.
Just give me 1 minute.
So we have the June 25th, 26th, and then the August 20th, because not everyone was present at each of those.
I
That's
see.
why I would do them individually.
Okay. I make a motion for the approval of the June 25, 26 meeting minutes.
So moved.
Second.
It's been moved and seconded. Let's do a roll call. Linda Stanich,
Aye.
Felipa Nesta,
Aye.
Oleniki Toobola,
Aye.
Rachel Mitchell,
Aye.
Margaret Hill,
Aye.
Marcus Cooksey,
Aye.
Claire McKinley Yoder, aye. Rachel Dennis,
Aye.
Joni Couch.
Aye.
The motion is passed.
Great, and I request making a motion for approval of the August 20th meeting minutes.
So moved.
Second.
The motion has been moved and seconded. We'll do roll call.
Abstain.
Margaret Hill,
Aye.
Claire McKinley Yoder, abstain. Joni Callis,
Aye.
Linda Stanich,
Aye.
Oleniki Toobola,
Aye.
Rachel Dennis,
Abstain.
Felipa Nesta,
Aye.
Rachel Mitchell.
Aye.
The motion is passed.
All right. Great, then we have, let's meet back at 11:05 to begin. You want longer? No, that's fine.
And kick off with the
11:05.
delegation before moving into the others.
Is that what you'd like to do?
Sure.
Great. So we're back on, and we're going to turn to Director Prusak, who's going to speak to delegation authority. That was an agenda item from yesterday. Can you remind me what page?
It's on page 13, Mr. President, and members of the board.
Of which,
So that's of the.
It's in this public packet too, and I think that's what the confusion was. It got into both. So I knew I was doing it during this public meeting, but we put it on to have a public meeting yesterday too. Everybody has a page 13, right? And I have invited investigator manager Erin Ferris to join me in this discussion to speak to it as well. So I do want to state, as I bring this forward and you're all looking for it, that I understand that some board members weren't here for the September 2024 board meeting and have expressed interest in having discussions about previously delegated authorities related to civil penalties. So I do want to assure everyone that since I've arrived, the delegated authority that is in this chart is not one that I've ever used, and I have committed to bringing it in November for us to have a discussion, but it's not on today's agenda. Today's agenda is, the ones that I've highlighted to make a motion for, but just wanted to make a comment on that before I jump into what is for today, and that I will bring that forward in November. So just for some background, the Board of Directors have used delegation of authority since 1999. And as just mentioned, in September 2024, I presented to the board the delegated authority granted to the Executive Director since 1999 for the current board to review, along with the request for updates to language. And today I'm asking for additional delegated authority as I'm really seeking new ways to improve efficiency and supporting our mission to protect the public. So currently, board staff present default final orders to the board for a vote to accept these orders. This occurs after the board voted to issue a notice for the proposed action. And to simplify the board's process and facilitate the timely entry of default final orders when the respondent does not request a hearing within the hearing request timeframe identified in the notice. So I'm seeking delegated authority to the Executive Director and the manager about that. And I'll just go through these and then we can take questions for any of them, which that's when I'll phone a friend with my investigation manager support. But also currently, amendments to notices that do not include a new basis for discipline must be brought to the board for their approval. And to simplify the board's process and to prevent delays in the posting of these notices, I am seeking delegated authority to the Executive Director and Investigations Manager. Evaluations are often used during an investigation, and if there's a demonstrable concern for a physical or mental condition affecting someone's ability to safely practice, as this is an investigation process, I am seeking delegated authority to the Executive Director and Investigations Manager. And the next two engaged are compliance specialists, and it really is just clarifying some previous delegations. But a compliance specialist currently proposed amendments to a stipulated order for extending probation under certain conditions, such as when a licensee requires additional time to complete the monitored practice. And I'm requesting delegated authority for the Executive Director and the Investigations Manager to extend probation when a licensee needs more time to complete the monitored practice. And the second one is the compliance specialist currently submit proposed amendments to a stipulated order when a compliance issue arises near the end of a probation period, allowing the licensee to demonstrate how they have addressed these concerns. And to streamline the board's process, I'm seeking delegated authority for the Executive Director and the Investigations Manager to approve proposed amendments to a stipulated order in such situations. And then lastly, I respectfully request that the authority to identify, communicate with, and appoint members of advisory committees and Fiscal Impact Advisory Committee for rulemaking purposes be delegated to the Executive Director and Deputy Director, Chief of Staff in accordance with ORS 183.333. So those are all of them, and now I open it up for any questions for myself or investigation manager.
I want to first highlight, and thank you for bringing these forward, the rationale for having more of these delegated abilities for the director and the managers, investigation managers. I think it's along the lines of the goal of improving our case resolution time and really trying to better serve the public and our licensees to get these, to shorten that amount of time. So I laud you all for bringing these forward. I do have a question, but maybe I'll let other board members if they have any questions.
I'll let you go first.
Okay, and this is maybe my English as a fourth language kind of reading. So it's the second delegated authority where it says approve the delegate executive director and investigations manager the authority to sign and issue amended notices that do not include new basis for discipline. So when I read that, that sounded like that's delegating the authority to amend any notice except for those that are new basis of discipline. Am I just reading that weird? Because it almost sounded like to me like a manager or executive director could then just make an amended notice of discipline. Yeah, am I?
Do you want to speak to that, investigation manager first?
Thank you, Executive Director Prusak. Good morning, members of the board, Mr. President. This would ultimately be notices that the board has already voted to issue. Ultimately, it would be to ensure that these notices are legally sufficient, that the language there within is something that we could then later enforce. In instances where we would amend them, it would likely be to omit certain language or grab typographic issues where we have typos. It's those types of amendments that we're discussing here.
So it's not the intention to delegate new discipline.
Correct.
Yeah. Does anyone?
There's a way.
Am I the only one in the room that reads it that way?
I also read it that way, but I think that would be a good question for our legal counsel.
If
Can it
maybe
be
there was,
interpreted like Marcus is saying?
or is there a way we could change the phrasing slightly to make sure? Because I read new basis of, not to include new basis of discipline. New basis of discipline in my mind is, oh my gosh, we found out in the investigation that, they spit into the PIC line site right before, and so that's new basis for discipline, but it doesn't exclude new discipline.
And I'm open to amending the language and making a modification to make it more clear, so everybody has comfort in that.
I like the word you just used. So like, instead of saying that do not include new basis, that exclude new basis for discipline, instead of the do not. Does that make it a bit better?
I think we need something that defines just like the clerical component that the investigator was talking about versus the ability to amend the notice. So if we could define, like have a more, like a stronger definition that says that the amendment is limited to clerical.
Yeah, like not substantive changes
Yes.
to it, but.
So without substantial changes, or Erin Ferris, is there anything you can think of off the top of your head?
Sometimes when we're looking at amended notices, sometimes the changes could be substantial in that we're omitting language, and that could end up being maybe by definition substantial if we're omitting a certain citation, or if we're updating the citations to make sure that they're the appropriate rules in effect at the time of the conduct occurred. Things like that occur when we're forming notices and sending them out. So I just want to caution that sometimes the change could in effect be substantial when we're omitting language or changing the citation to be the legally sufficient citation.
I also wonder if we tried to say substantial changes, would that include something like this person had the notice says that they had 8 months of monitored practice, but they actually had 8.5. Like that, you know, like, would that also fall under substantial changes? Because I think that's kind of where we're going with this. Director Prusak? Investigations Manager?
Yeah,
and
I'd like,
I want to make sure I understand your question. Notices are the proposed action, so when the board reviews the cases and they vote on a proposed action, it's those notices that we send out, not to be confused with stipulated orders, where we might be discussing monitored time. And I do want to be clear what we meant by the verbiage, do not include new bases for discipline, that we wouldn't include fact patterns where the board hadn't already reviewed the fact pattern. That's what we meant by new bases for discipline. What we would include in the notice would be facts and citations that the board would already be aware of by way of the executive session meeting.
Could simply adding at the end of that sentence, nor new discipline, be enough clarity for my issue?
well, it says do not include new basis for discipline, so maybe removing new basis. You need to say that?
New discipline.
Okay.
Does that just have the word basis?
Okay.
That's
Do
what
not
I'm wondering.
include new.
But I think we're getting advice that we do need to. What's the difference?
Well, I think just to clarify, just to make sure that I'm understanding exactly what the board is contemplating here. So it sounds like the board's contemplating a potential delegation of authority to the executive director and investigations manager to sign and issue amended notices when the amendments are not adding additional bases for discipline.
No.
I think sort of capturing that this is to kind of adjust an existing notice, and that if there were to be additional facts that could be additional bases for discipline, that those would come back in front of the board for consideration. Is that kind of what the board's contemplating?
I think that, yeah, I mean, I think what we want to make sure that we don't create is the situation where we decide on a discipline or a notice, and then we have this delegation that says that it can be amended, and that seems like a very open and broad possibility for amendment. And we want to kind of, I think that agreeing to the fact that if there's a clerical error or the language needs to be tightened up, that doesn't have to come back to the board, because we already had decided on what we wanted to do. So how do we put that in a legal language that isn't so broad that it could be changing what we intend, the intention of changing the notice, or changing the notice so it no longer matches the board's intention?
Yeah, and just to make sure, so I think it sounds like one of the issues the board is concerned with avoiding is, say, if the board previously voted to issue a notice of, let's say, 30-day suspension, that the board would not want staff to be able to change that discipline to something else. So the concern is kind of making sure that you're not changing the proposed sanction, and that the changes would be primarily to address, as I have here, sort of clerical components, language, and citations. Okay.
Because yesterday we,
Be careful what you bring up in public meetings, please.
but if we voted on something yesterday that we had to vote on because of citations that needed to be corrected, we would not need to see that again?
I think that's one of the things that staff are contemplating having the board delegate, is to address, and I'm trying to think of how to phrase this in a way that like fully captures the board's intent, because I understand, I think, what you all are trying to do, and I want to make sure that a motion reflects it. So this would be, and hopefully somebody else is listening as I'm thinking
Yeah,
out a little bit.
Sorry.
Right, so to delegate to the executive director and investigations manager the authority to sign and issue amended notices when the amendments address things like clerical errors, adjusting, language to, be more accurate potentially, or to be, sort of fully accurate, and to ensure that citations are correct. And I think the board discussion today, so I think the motion could potentially say something like that. I think the board discussion today informs staff's understanding that this would not be situations of changing the proposed sanction, adding new bases for discipline, right? So, let's hypothetically say there's a notice that identifies 3 different violations of the Nurse Practice Act, 3 different alleged violations of the Nurse Practice Act, that if additional facts were to be brought forward that indicate there are actually 6 potential violations of the Nurse Practice Act, that would come back to the board for consideration of those additional things. So I think if everyone, and certainly inviting additional language from board members to make sure that this is accurate, but that it sounds like really the kinds of changes being contemplated are clerical things, adjusting language to be fully accurate, and making sure that citations are correct.
And that's what I wrote down: clerical errors, accurate language, correct citation. Is there anything else, Investigation Manager Ferris?
I was going to read it for the board.
Great.
To see how it sounds. The board delegates to the executive director and investigations manager the authority to sign and issue amended notices when the amendments address clerical errors, accuracy, and corrections for citations.
You all feel comfortable with that one? Okay. So please note that so that I can have you make that motion, since you have it written in front of you exactly how they feel comfortable with.
Will do.
Not to dig, well, yeah, I guess to dig in the weeds. Correction to citations. So what does that mean?
Yeah, thank you for that question, Member Kalis. That would be, again, I think I mentioned maybe briefly a moment ago, making sure that we're using the rules and statutes in effect at the time the conduct occurred. Again, just ensuring the notices are legally sufficient for enforcement, making sure that we identified the right citations to address the conduct.
So it's citations for statute and rule.
Correct.
Okay.
Yeah, and every once in a while there's a date and a time, and then there's a change, and maybe it wasn't captured, but it's the correct one, just slightly different. Yeah.
Who will sign those then, if they're?
So it gets delegated to myself or to the investigations manager.
And then I just wanted to clarify, if anything is pulled, it still comes back before us.
Oh, yeah, that would
Yeah,
not be.
And then third question is what the evaluations, is that something that would be made knowledgeable to us? Or when you talk about the evaluations and those, would that ever be brought to us and saying that these are, or is that just?
So can you ask the first one again?
Which one? Who signs?
No, sorry, the second one.
Anything that was pulled would come back to us.
Well, so Investigation Manager Ferris, do you want to speak to that? You'll do it clearer than I. When is there an instant? So when is there an instant if something was pulled it compared to what we're asking?
I think in the instances, Member Standish, where a case is pulled to work with the licensee around a voluntary substance use evaluation or mental health evaluation or other evaluations as necessarily identified, I think we would use that same approach in investigative work. If somebody's voluntarily willing to do that work, that would become a part of the fact pattern in the board report that you would then review in executive session. It wouldn't be something uniquely identified in and of itself, but again, would be a part of the fact pattern. Similarly, I would, in thinking about this delegation, I was thinking about how many times we have ordered these types of evaluations in executive session. I think you wouldn't see a dramatic increase because we'd use the same discretion. We would use the same discretion if somebody's voluntarily willing to go and get an evaluation versus the instances where it might be necessary to use an order. And then we'd have really strict protocols in-house, and we would be consulting with our CDAC 3 on staff when we are considering order these evaluations. Again, when I thought about the process, I considered that this would become a part of the fact pattern that would be presented to the board when the case was prepared for board review.
Thank you. And that got to number 3, and we'll get to number 2 over here.
I think Board Member Standich, make sure I'm a little bit closer here. Just to clarify, so this delegation would be specific to notices of proposed discipline. So things that the board had already voted to issue a notice of proposed discipline on, and just those documents, not necessarily like a stipulated order, a settlement agreement kind of document. For this particular point number 2 here is we're really just talking about notices of proposed discipline. Does that answer your question? Okay, great, thanks.
Questions about any of the other ones?
So I have a question. I think we were kind of talking about it, but I kind of got lost. For the order of the evaluations, I think what I just understood from investigative manager Ferris was that you guys would be using it as a fact pattern. So, but you would be only doing it if the licensee was volunteering it. Because the way that I'm reading the delegation, it seems like you can order it.
Right. Thank you for your question, Member Mitchell. I would say that we often rely and do cooperative type work with licensees. So if they offer or if they are willing to voluntarily do an evaluation of whatever need during, relative to the fact pattern, then we wouldn't order it. It wouldn't be necessary to then order the evaluation. In the instance where we have information by way of the investigation that indicates there may be a concern, and we need to use the authority around ordering evaluations, that's when we would use it. And that's actually fewer than maybe one would assume. I think, again, I've seen a handful in the year and a half that I've been at the board, and I don't know that we would use it in more instances than that even now. Again, we would use great discretion when using this authority to order evaluations, and we would do this in concert with our CDAC 3 who is on staff.
And so this would expedite, so with us having meetings every 2 months, this would expedite the process so that by the time we saw the board, we would have this important piece of information.
Yes, sorry if you just spoke, but to jump in, yes, it is already a tool that we are statutorily authorized, and it will allow a little bit more of an efficient process.
I think that ordering evaluations is something that should come to the board because I feel like it's kind of intrusive, and the licensees should have the opportunity, or their situation in case should be heard by the board of their peers to be able to order those specific valuations. I am totally in agreement with if you guys are identifying during the investigation what type of evaluation would be most appropriate, and then asking them and they volunteer to get the evaluation done, I think that would be appropriate. But I think that if we're going to order it, that case should be heard by us before we make it official order.
I hear where you're coming from there. And in my limited, year and a half plus here, we've had a lot of problems of not getting that evaluations in a timely manner. And really, when you're kind of balancing the public risk and the practice of nurses and certificate holders, I've seen numerous cases where that delay in waiting has really affected, I think, potentially patient care and risk. I hear what you're saying about that piece, that it can be intrusive, but I think you have to balance it with what is our duty to protect the public and ensure nurse wellness. I think that like a lot of the you know, when we're talking about like neurocognitive and psychiatric and substance use orders, I think those have been really few and far between. And when, you know, we've often had cases where we're like, we really could use this information right now to make a decision. I really think you have to weigh that balance with how much of a delay and the kind of compromised care that could go on.
Well, since they're so few and far between, we could always have an emergency session if there was something that needed to come up. I just think that it's being able to order something like that, a test like that, needs to be a decision by the board. If it's going to be an order. If it's volunteered, it's totally different.
What do other board members feel?
Maybe that was part of my third question that I just wanted to make sure. So to streamline and make it where we don't have as many cases as we've seen and influx in that, when you order that, does that come back before us with the results at some point in time? Yes.
I'm going to let, I know the answer, but I'm going to let investigation manager Ferris speak to it.
Yeah, ultimately, the results, yes, thank you, Member Stanich. The information would be used for twofold, right? To identify what necessary investigative steps we need to take to glean additional information for public safety mandates, but also to identify potential resources for our licensees. And yes, you would have the information presented to you when the case is ready for presentation to the board for the action to be voted upon. The disciplinary action to be voted upon, I should say.
And I kind of agree with Marcus then. I feel like that is giving us information when we have to make the, I think it's helping us, it's aiding us, so I agree with that.
Well, and I will just elevate one more time. It is several of the health professional regulatory boards have it in their statute to use as a tool in investigation. And it definitely is a very, I hear what you're saying, Board Member Mitchell. It is a privilege that we have it, and we take it very seriously, and think that those discussions would, you know, they are things that would come to you all. And if at any point it seemed like a wrong decision, we could always change it. But I do think that it does at least help in some of the conversations we even just had yesterday.
Do you mind if thank you. So I appreciate what you said, Board Member Mitchell, because I think the other thing is that these evaluations can be very costly. And so if we order someone to do it, it's as if we are causing someone, or we are inflicting like a civil penalty. And so I guess that is my concern also. Anyways, I just wanted to put in that thought.
Can I highlight for the board? Oh, sorry, go ahead.
Oh, and the other thing I want to say here is that that I feel like what our executive director and our investigations manager are excellent and make very good decisions, but also realizing that some of these delegated authorities that we've had in the past are 26 years old. So well beyond our group, the people that are here, this may influence what's done.
Member McKinley-Yoder, members of the board, Mr. President, I just want to highlight that in discussions when considering this delegation and asking for this delegation, even with the investigative department, I have highlighted a number of times in our department meetings that this is not, if in the event the board votes to give us this delegation, this is not something that we can misuse, that we have to be very discretionary in our use of it. And really, in theory and application, it wouldn't increase we wouldn't increase the usage of this the authority more than the board already sees this when it comes on the agenda to you to decide upon. So ultimately, it would stay about the same frequency. So if we're worried about the financial implications for our licensees, it would, in theory, be no greater than if you yourself reviewed the fact pattern and voted to order the evaluation.
I completely hear where you're coming from, and completely respect that. I think for me, the decision point is our job, my job as a board member, is to think about protecting the public, less so the licensee. Oh, I hate to say that, but we're here to protect the public. And if there's a need, I feel comfortable with that delegation.
I think some of these evaluations can be also for the licensee. Very often are about the licensees getting treatment and yeah. So I don't think it has to be an either or.
Well, but I feel like just as the person that is looking at the big picture of all of the stuff that goes on from the board and the staff supporting the board, it does both. Because it allows, the reason why we've been fighting for so long to get into alternative discipline is this idea that the sooner that we can intervene, the sooner we return someone to wellness, the sooner we're protecting the public. And so that's why we brought this forth. And again, you all make the final decision, but I wanted to have that discussion. That has been my goal and my vision since I got here of what things that we can do to uphold our mission. And when we added nurse wellness into it, but I do appreciate the discussion of how careful we need to be, and that delegated authority could potentially extend beyond any of us unless we stop it.
Personally, I like having it. I understand where you're coming, Board Member Mitchell, but if you look at some of these, it's like these cases are from, something that happened in 2022 or, like 2023. It's like, okay, this is something that happened a while ago. So if they had this authority, then maybe it would be able to get in front of us faster and we could, deal with things in a more, I don't want to say that it's untimely, but we can deal with things faster so that it is better for the public.
Yeah, I mean, I think, again, being careful, we're all in a public session, but timeliness is part of this, and we are in a place, it's not a mystery that people know many regulatory boards have been behind over years, and we are doing a really great job of catching up, but I do worry about the fact that we now have more complaints coming in than we've ever had. Ever. And again, not just the Board of Nursing, every board in the state and every board across the country. And so how do we as the leadership team supporting the board do the work and uphold our mission? So it's just a thought for another opportunity.
Is it okay if I move on to number 4 and 5? Okay, so this, I really would like to welcome the board's discussion on this one. Just because I wanted to get clarity on the aspect of extending probation. Usually, historically, when we talk as a board on when to extend probation, we kind of see which timeline fits best. Is there going to be an algorithm are we trying to match like a HPSP timeline? Or what is the plan for that? Because I worry about for some licensee, we might vote as a board and say, no, we don't want to extend their probation. We just think this is it. But if we give that authority, then it can just be extended and it doesn't come to us before it was extended, versus if we were not going to be okay with extending that kind of person's probation.
Do you want to speak to that first, investigation manager first, and I can jump in?
Sure. Addressing the first delegation around the compliance work that we do, That one is one I believe that's already a delegation we've already had, and we're updating the language to. It really is to accommodate the licensee and their success while also upholding public safety mandates. It's in those scenarios where life happens or employment issues happen where we want to ensure that the licensee has an opportunity to truly complete their monitored practice and meet that condition in their stipulated order. So that's what that delegation is truly intended to do. It really isn't meant to extend probation or amend the STIP beyond that monitored practice piece. And then the second to last delegation that we're asking about in relation to the compliance specialists is again to ensure the success of the licensees and ensure that they've mitigated whatever compliance issue that might have come up in those last 6 months and ensure that they're returning to wellness. So really, they really are very focused. They aren't meant to be vague in the delegation. It's meant to be that we have those two very specific authorities given to us by you so that we can exercise both extending and or amending those probation stipulated orders.
And can I speak to, I'm going to add on, is
Yeah.
that I made actually a mistake in this because instead of redlining, I removed. But this, remember when I came to you all and said, for those of you that were here, so it seems like I've been given this delegated authority since 1999, but I want to make sure you all know about it, and I want to make sure I actually do have it. And so Brandy and I went back through every meeting minute since back in the day, and it's attached in that now, and I wanted to make sure I had it and then brought it to you. And then we clarified, because what I found out what was potentially happening was, yeah, the board gave it to the executive director, but then the executive may have internally delegated it, and I really didn't want to do that. Well, in this case, it was delegated to the compliance team, and we want to make sure it's delegated to the right people, and then we discuss it with the compliance team. These are discussions that we have weekly when something comes up like this, and we, don't want to delay it.
I think again, it's very vague and it could be interpreted a lot of different ways. When I read the authority to amend stipulated orders under certain conditions, I mean, that could be anything, including but not limited to monitored practice requirements and extending probation due to compliance issues. I mean, to me, that's pretty much anything. And so I think that if there's a way to change the legal language to possibly really better reflect the issues that you guys are seeking to expedite, I think that would be more helpful. Again, I don't want to get into a situation where the board has decided on either a punishment or where the intention of what we had decided here as a board gets amended and it gets skewed and goes down a different path.
You know what I think we should do for those two, so 4 and 5, is instead of having to wordsmith it here like we did for the other one, I can pull these and come back in November and make those more clear based on what you've all just recommended. I think that will be a good thing that we can do amongst us behind the scenes to support you. Not move those two forward this week.
And on number 4, I had a question too, like how many times can this be done? So maybe we can address that.
Yeah, and I think what we'll do is include kind of our internal policy and procedure of how we talk about these things. Okay.
Okay, so I just, for the last point, which is delegating authority to identify, communicate with, and appoint members of advisory committees and fiscal impact advisory committees. I'm wondering what the process has been in the past, and I think that it would be really helpful for this to be, especially because it's advisory. I'm wondering if it could also be something that, so it can be more transparent to the public, about who is involved in these advisory committees, so that we have like a diverse group.
Yes. So this is for rulemaking only, and it is something that we've been doing. I want to make sure it's very clear in delegation. And we've actually, since my arrival and since us starting a DEIA committee and since us having a chair of that committee and having plus we are working to make sure that they are expanded and diverse. And yeah, so again, wanted to clarify something in this authority that may have been happening.
I would actually really appreciate if we, as board members, have a list of all of the advisory committees and who's on them. I mean, I know that I'm a relatively new board member, but so that there's a lot of work that's been going on behind the scenes, but I think that that would be helpful. And thank you for clarifying that this is something that the board is already doing. And you just, because I didn't understand how historically that was those committees were put together.
Yeah. So since I've arrived, we make sure policy analysts cast a wide net and ensure anybody who is interested in joining can. They've been quite large the last 2 years, 21, 31, 47, 62, 63, really large. And when the policy analysts present to you all, they often include the members and their presentations, but we can find a way to make sure it's much more explicit up front before the work begins.
So are these committees, like, is a public notice posted that they're forming?
We follow all rulemaking advisory, what do you call that, committee rules. Oh yeah, we follow all the rules, all the meeting laws, all the public meeting laws. They're recorded minutes, they're on our website.
All right.
Mm-hmm.
And they're sent to us as well, are they not?
Yes, and there's been historically a board member on many of our rule advisory committees. I know Claire McKinley-Yoder has been someone that has served on one. And as we open ones in the future, that'll be exactly what we do. When we have to, open Division 70 to update some stuff around HPSB. And actually prior to this board, all the work in the 60s, the CNA member sat on every single rule advisory committee. I believe, Claire, before you were on the board, you were on Division 47 and then on the board Division 21. It's nice to have that bridge.
Yeah, I agree. I think there should be a board member on one.
Yeah, I mean, there's times when there wasn't one that stepped forth, but delegation, all the CNA stuff, and 21, there always has been.
So if we can switch gears, I have a question on number 1, just to clarify for myself.
Okay.
This would mean that, so let's say we ask the staff to see if they can get a stipulated reprimand. If that goes through and the licensee signs, does this mean it doesn't come back to us?
No, so this delegation is about issuing a default final order once the board has already issued a notice of proposed discipline and the individual doesn't submit a timely hearing request. So again, this one's particular to notices. So right now, the board would vote on the notice and then the matter would come back in front of the board to consider a potential default. So this would give staff, the staff identified in the delegation, the ability to enter that default final order, only in circumstances where the person did not timely request a hearing. And if there were questions about a late hearing request or something like that, those things would be brought back in front of the board.
We currently see the signed stipulated orders that we have requested, and we will continue to see those.
Yeah, this doesn't affect stipulations at all.
Okay.
This is just notices and then the default final order in situations where a default is appropriate.
Executive Director Prusak, would you like to proceed? I think we're done with the.
Yeah, I think what we need to do is remove 4 and 5 and then have investigations manager do the updated language for 2. So I'll read 1, have her read 2. I'll read 3 and 6, unless there's any more questions.
No, I think we're ready for a motion.
All right, thank you. So I make a motion that the board approves to delegate to the executive director and investigations manager the authority to sign and enter default final orders when the respondent does not request a hearing within the hearing request timeframe identified in the notice.
So moved.
Second.
The motion has been moved and seconded. We'll do roll call. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Towabola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
Great, and I invite investigations manager Ferris to read the second motion, please.
I make a motion to the board approves to delegate to the executive director and investigations manager the authority to sign and issue amended notices when the amendments address clerical errors, accuracy, and citation corrections.
So moved.
Second.
The motion has been moved and seconded. We'll do a roll call. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Towabola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
Great. I make a motion that the board approves to delegate to the executive director and investigation manager the authority to identify the type of evaluation and sign orders for evaluations pursuant to ORS 678-1131.
So moved.
Second.
The motion has been moved and seconded. We'll do a roll call. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Nay. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Towabola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Nay.
The motion is passed.
Great, and I will be removing 4 and 5 and coming back in November with some clarifications for you all. I appreciate the recommendation. And so final is I make a motion that the board approves to delegate to the executive director and deputy director the authority to identify, communicate with, and appoint members of advisory committee and fiscal impact advisory committee for rulemaking purposes in accordance with ORS 183.333.
So moved.
Second.
The motion has been moved and seconded. We'll do a roll call. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Towabola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
Okay, thank you all for the really thoughtful discussion. We all get to learn so much when we do this work transparently in public together. Thank you.
Well, we have a little change to our meeting agenda, and I see that our lunchtime guest is here and ready to go. Is our lunch ready to go? Okay.
Our lunch guests and our lunch are ready.
We're not eating our lunch guest for lunch.
So everybody turn off your mic, just as a reminder, unless you, board president, you can speak. Everybody else turn off our mic as we enter and not have the discussions we had before.
So it looks like we're pushing our policy analysts' motions all to the afternoon. Maybe we can tuck some in right before we do the public, at 1 o'clock, but yeah.
Yeah, so that means
let's meet back at 12:05, so 10 minutes to grab lunch, and then we'll have Janice start then. Working lunch.
before we get started, I'm going to mute myself here. All right, excellent. Okay. Good afternoon, everyone. For those of you who don't know me, my name is Janet Bitton. I'm the Executive Director of the Center for Nursing, and as many of you know, we are the state's Nursing Workforce Center. We're a nonprofit organization that's been around for about more than 20 years, specifically to look at Oregon's nursing workforce with the idea that we want to make sure that every Oregonian has access to a well-qualified, very well-prepared nurse whenever they need it and for however long that they need that person. So a lot of the work that we do is gathering data around the nursing workforce and then trying to identify what are those gaps that we have. Where are we missing? Where are we missing nursing that we need it to be? What do we understand about that? And how can we really look at solutions that's the effective solutions that will solve these problems that have been plaguing the nursing workforce for decades? One of those problems is what I've come to talk to you all about today, and that is about the nurse educator workforce. So I want to start by just sharing this slide. Is everyone familiar with this story? That Oregon cannot grow nursing education programs because we cannot recruit or retain faculty. Who has heard this narrative before? Yeah. This narrative has been around. I worked at the Oregon Center for Nursing for 15 years, and this is one of the very first things that I heard. We actually went back and looked at some literature that we found all the way back into the 1970s that was showing that the challenge of recruiting and retaining faculty has gone back many, many years. So if for any of you who are familiar with the Oregon Center for Nursing, you will find that when we find a problem that's kind of persistent and has been going on for decades, we get really interested about what is it at the very root cause? What could we do about that problem? Because the solutions we've been trying may have been making a dent, but it's not really changing. We had a really interesting opportunity in the 2023 legislative session where the legislature passed House Bill 3396. There were a lot of elements, a lot of pieces to this bill, but one of the pieces was that the bill allocated state funds to the Oregon Health Authority to grant to the Oregon Center for Nursing specifically to build programs with public nursing programs, nursing education programs, to look at retaining and recruiting faculty in the state. And we were allocated $5 million for this purpose. So what I'm here to tell you about today is I want to tell you about the program that was created with this bill, what we are doing and have done with that money so far, a little bit about where we are in the process, and also be able to answer any questions you have. And at the end of this, if there's any questions that you have that is even not related to nursing education, I'm here for it, because I don't know that this is going to take up a full hour, and I want to make sure that you all have some time maybe to go outside and enjoy the beautiful weather outside, because it's amazing. But I'm here to answer any questions that you have. The one thing that I do want to put a caveat on here is that the money that was allocated from the legislature was really specifically for public universities and public community colleges only. So in Oregon, for nursing education programs, OHSU is the only nursing education program that is publicly funded. Yes, they have 5 campuses, but it is considered one program. The other programs that we have with bachelor degree programs, those are private, and that's not what's in the language here, and that wasn't the intent of the legislators. So this entire project, what we have done so far, has been very specific to public universities, public nursing schools. All right, so let me go on. So when we were told that we were going to be getting this allocation, we really started to go back to the drawing board, because like I said, when we are presented with a problem that has been going on for decades and it doesn't seem like the solution has been reached, we get really, really curious. And now that the legislature has allocated some money specifically to looking at this problem, we kind of came up with this central research question, which is, what are the key factors driving faculty turnover, hindering recruitment and program expansion in nursing education programs, and how can targeted investments mitigate these challenges? The Oregon Center for Nursing wasn't given $5 million just for us to have the money and then just to pontificate about it. The idea was we were going to be taking this money and then putting it right back into the community colleges and the nursing programs specifically for this. So this was the key question that we were trying to answer as we were structuring the entire program. So the program that we created is called the Recruiting and Elevating Nurse Educator Workforce, which we also call RENEW. And yes, we developed that name specifically so we could have that acronym because it's a good way to describe it and it's easy. So really the vision for this is that we really want to make sure that we have a stable and well-supported and adequately staffed nursing education system in Oregon that can meet the state's growing healthcare workforce needs. I've come before this board before and talked a lot about how the number of people that were graduating from our nursing programs isn't going to meet what the need is that's been determined by the Oregon Employment Department. That kind of doesn't matter because we have so many people coming into the state. We still need to have a strong internal nursing education system for a variety of reasons. We need it because, well, we need it not only because we want to be able to grow our own, we want to be able to give economic opportunity to the people who live within our state who want to pursue a nursing career. So our approach to this is that we were going to combine our statewide research, do some stakeholder listening tours, and then do some targeted grant funding specifically to our public nursing education programs to improve the recruitment and retention of nurse educators. And you can see these are the goals that we reported to the Oregon Health Authority that we were going for. We wanted a 5% reduction in faculty turnover, a 5% reduction in educator vacancy rate, and then also be able to demonstrate some long-term program sustainability. So even though we have $5 million can go really quickly, but we wanted to make sure that anything that we come out of this is something that can be implemented permanently or long-term, or the solutions that we can find isn't just going to put us back at square one. We're going to the beginning. We want to make sure that we can have this go on into the future. So this is kind of how we designed the program. We first put together a listening tour. These are focus groups, essentially, where we went and talked to nursing education programs across the state. We went to all 5 OHSU campuses and many community colleges because we really wanted to understand the lived experience of Oregon's public nurse faculty. Our experience when we have done our programs and the work that we've done around well-being for nurses has really proven that there are not one-size-fits-all solutions. You can't go in and say, this is what we're going to do for nurse well-being and it's going to work everywhere. That's not really accurate. We really kind of, as we were putting this together, we were recognizing that the issues that might be happening at Tillamook Bay Community College would be very different than the issues that are happening at Portland Community College, also very different than what might be happening at Treasure Valley Community College all the way over in Eastern Oregon. So we wanted to be able to physically go to each of those places and talk to the people and really understand what was going on with them. The second part of this project were grants to schools. So using that information from going and talking to all of those different schools, we'd be able to glean out what were the things that that particular location might need in order to improve the recruitment and retention of the nurse faculty at their location. So after we did the interviews, then we had a really good sense of what they needed. Then we asked them to give us a proposal based on the interviews, based on the conversations. We gave them some ideas of what they could do individually and basically said, you can ask us for however much you want. Like we don't really have a limit on this. You can ask us for whatever you think you need. You just need to tell us what you want and put a budget together for it so that we have a way to hold you accountable and be able to report back to the legislature how the money was spent. As we do that, the other thing is that the Oregon Center for Nursing is going to pull together some of the strategies that's going to be fostering that sustainable growth for nursing educators. We're going to pull those resources together. We're going to take the information that we've learned and be able to share it all throughout the state of Oregon. And also we're hoping to share it with other parts of the country for other states that are also dealing with nurse faculty shortages and having that be a big barrier to growing their nursing education programs. And then finally, ongoing support. The final part of this is because we recognize that in Oregon, a huge portion of our nursing education is provided in the private education space, and this grant did not cover the private education space. We know that there are some solutions that could be done on a statewide level to benefit all nursing educators and all nursing education across the state, regardless of whether they are publicly funded or not. So the final part of it is to establish a statewide initiative to fuel future investment and decision making. And that goes to the goal of long-term sustainability. So this is the timeline for our project. You can see that it started in the September of 2024. That's when we began to conduct the interviews. Our request for proposals opened in February of this year. It closed in May. We selected all of the projects in June of 2025. We released the funds for those projects in July, and here we are now where the interventions are starting to begin. So we have already completed the interviews with the schools. We've already collected the projects that they wanted to have funded. We've already funded them. Now the interventions are beginning, and we are going to be monitoring that through the next year. The idea is that they don't have to have their projects complete for 2 years. And then as they get those completed, we're going to continue to evaluate. Our evaluation period ends in 2028, and then we will submit a final report to OHA in November of 2028. This is how the funding is allocated over the next 4 years. And I think that this is important to know because a lot of times when I say, well, not a lot of times, in the times that I have talked to people and said, the Oregon Center for Nursing was granted $5 million, they immediately start trying to do the back of the napkin math in their head and try to figure out what could you possibly spend the money on. What I really wanted to share with you is that 70% of that money is going to project support. Most of that money is going to be spent in going out to the schools or in that statewide project that we're going to be putting together. The direct expense of the 20%, that's going to be funding the staff we were hired for this purpose, the travel costs of driving around this beautiful state to conduct those interviews. And then OCN has a 10% indirect rate of what we are collecting for the people that may not be working on it, but we really need those people to have OCN, keeping OCN alive so that the rest of the 90% of it can function. So let me tell you first about the interviews and how the interviews went. We conducted the interviews from September 2024 through February of 2025, visiting 18 different campuses across the state. I think there were only 3 community colleges that chose not to participate, but everybody else did, and there was 126 people that were interviewed. In most of the places that we went to, we tried to split it up where we would have the didactic faculty be interviewed in one session, the adjunct faculty interviewed in another session, and any administrators that might be a part of it also to be interviewed in another section. That way we could allow our focus groups to be able to be, open and not feel like they're saying anything that might be retaliatory. What was so interesting is that from the faculty interviews that came back, there was a concern a little bit that maybe some of the educators might not want to be open and be sharing their situation. And, there's an element of trust that we wanted to build with them. And the staff that went to all of these places have reported that all the nurse educators were extremely welcoming, extremely open, really excited to be able to talk about this particular topic. So it was a pleasant surprise. Our nurse faculty is kind of great. This is what we heard from the faculty in the tour that we did. Most full-time faculty roles are being filled and retained. So when we talk about nurse faculty in this particular context, we're not necessarily talking about the full-time roles, the full-time didactic roles. However, the adjunct roles, that clinical nurse educator, that's where the pressure point is. However, that is a structural feature of higher education, and it's not specifically a nursing issue, if that makes sense. So when we are talking about trying to bring nurse faculty on as a part-time adjunct position, typically that gets paid, that the pay structure is different than what a full-time would be. The pay structure is different as what a part-time FTE would be in practice. There's a lot of differences that might be happening as far as hours and workload, all of that. But that is a structural feature of higher education, and it's not specific to nursing, is what we found. some of the biggest challenges that we experienced that we heard from people was the workload. One of the things that is not consistent is the concept of having a nurse faculty also be a clinical person. So having somebody also fill that clinical role, that isn't consistent. There are some places where they have a faculty who's just didactic, and then they have faculty that are just clinical, but other places they have to do both. And so when that happens, then that really piles onto their workload. Go ahead. Yes. Yeah. Yes, that's it. Yeah, yes. Anytime that they're trying to bring somebody on a part-time level, at a part-time way, we're kind of lumping them into adjunct. I know that the Nurse Practice Act calls them clinical educator associates. I think that there's different names for them. When we talk about adjunct, we're really looking, the clinical educator really is the majority of what we're talking about there. That is what we found.
Executive Director Benton, just a moment, I was going to have one of the policy analysts help clarify something you said, and especially in relationship to that question.
So in Division 21, we don't really identify the difference between a full-time faculty and an adjunct faculty. We really just speak to what are the qualifications of the faculty, and it's up to the institution to determine that, based on these qualifications, what setting they teach in, whether it's full-time in the classroom, whether it's part-time in clinical, but you can also have adjuncts who teach classroom courses, not just clinical courses.
Yes, go ahead.
This is just full disclosure of, as you've been going through the presentation, I'm having to pull myself back with clarity on one thing over and over with the interchanging of nurse educator, nurse faculty. I work in the hospital also as a nurse educator. So it's just, and I have to keep reminding myself this is nurse faculty educator, not nurse educator in terms of MPD, professional development that works in the clinical setting at the hospital.
Correct.
Okay.
First of all, happy Nurse Professional Development Week. Second of all, yes, I'm using those terms interchangeably for this particular conversation, and that is a good clarification, and I can make that clarification in the future. Yes, for this presentation, even when I say nurse educators, what I mean are the nurse faculty that are working in an education setting.
Because I can see somebody looking at this, not listening to you, and thinking that this has to do with nurse educator in the hospital setting versus nurse faculty educator.
Yes, I can also see that. I also have talked to a lot of nurse faculty who call themselves nurse educators. So there is an interchangeability of the vocabulary that we use, but I absolutely agree that especially when we're talking about this particular project and how we're talking about faculty, I can definitely see how there might be a confusion there. You're welcome. Going back to the biggest challenges, academic culture. One of the things that we found is that when nursing faculty are being recruited, in some of the places where they're being recruited, someone from the community college will go to the local hospital and they will recruit from the hospital, and they will bring them into the academic setting. And so our faculty are being recruited from hospital settings, and they're not coming from academic settings. So it's a culture shock in a way where they're coming from a clinical setting in the healthcare industry to an academic setting in the higher education industry. They're two different industries, and sometimes there's a little bit of a culture shock there. They also, and then kind of going back to, and then along those lines, there's a lack of support. There's a competition against an industry, which is healthcare, that has a very different compensation and work structures than higher education. The two are different. And so that's something that was a big challenge that we heard about trying to be able to recruit, is that they were coming from this industry of healthcare that have very, very different way of working, a very different compensation structure going into the higher education where they have to move into a different culture, a different structure. And they sometimes weren't aware of that leap is not as easy to make as you'd think.
What is the difference, I mean, between the two salaries in the private industry or the healthcare versus the adjunct faculty? Is it like a 60% reduction that you kind of saw? I don't know.
Yeah.
I'm curious. Like, why was the transition so hard? Like because it was like such a huge reduction in the amount that they were making, or?
Sometimes it was, sometimes it is, and sometimes it isn't. It just really depends. If you look at the Oregon Employment Department figures and they compare a registered nurse to a nurse faculty salary, the difference is like 7%. There's a 7% decrease in what a registered nurse would make. However, you have to think about how the Oregon Employment Department categorizes registered nurse. They're not taking into consideration nurse managers. They're not taking into consideration nurse practitioners in some ways. They're not taking into consideration of that. And many times when we listen to the argument about pay for faculty, those faculty are required to have the higher education than what a registered nurse would have. So even though the Oregon Employment Department is saying that it's a 7% difference, it actually turns out it can feel like a bigger difference. When we did a wage study last year, looking at where we surveyed nurses across the state, asking about their wages. And one of the things that we found is that especially with the population that we're looking at, again, we're not looking at private universities, we're looking at the public community colleges, and we're looking at OHSU. A lot of those faculty are teaching on a 9-month contract that they just extend out to make sure that they're paid over a 12-month period of time, but they're really only contracted for 9 months worth of work. When you look at it that way, there's a bigger difference. It can get all the way up to 40% difference in pay between what you would be making in practice and what you would be making. So it really depends on how you look at it. For some people and a lot of people, especially I would say nurses who have higher educations, a master's degree or a doctoral education, and they want to go into a faculty paying position, they are sacrificing a lot as far as money compensation to go from the healthcare industry into the higher education industry.
And I just want to clarify, you're not talking about full-time employees, right? You're just talking about these adjunct faculty.
In this particular case, when it comes to the compensation, I think that it is both. I think that we do run into that obstacle for both. That's one of to be working on as far as the paper that we're putting together and the resources that we're putting together is to really flesh out where it's different for full-time faculty and where it's different for the adjunct faculty. Other questions?
I had, so did you find that a large, and you might not even ask this question.
Yeah.
Did you find that a large number of faculty that were dually employed, so as a nurse faculty, maybe full-time, maybe part-time, but also employed in a clinical capacity, not in a clinical education capacity, in like a direct patient care kind of a role?
I believe so, but I'm going to have to go back and check because I don't have the numbers necessarily on that. One of the things that kind of goes back to the academic culture is the clash between the academic culture and the healthcare culture is there was this kind of belief that you should be, that someone who's an adjunct faculty could be making a living wage. And they wouldn't necessarily have to they could work part-time in academia and be making a living wage in the same way that in healthcare you could be working part-time and making a living wage. And that's just not so. But in some of it really goes to that culture clash that we kept running up against.
And then my other question, which since you asked for questions, was did you find that most programs actually used a large number of adjuncts? Because I know some public programs, full-time employees cover clinical education. Other programs, basically almost all clinical education is done by an adjunct who's part-time, hired on a term or semester basis, and then may or may not continue.
There was, from what I remember and from what I understand, and this will come out in the reporting that we do when we've got that all together, it wasn't consistent. It's not consistent across the schools. There's some schools that, exactly like you say, there are full-time didactic faculty, and that is what they do, and then they hand their students off to an adjunct part-time clinical educator for their clinical part of their education. In other places, that full-time didactic is also the clinical educator, and especially when you have that sort of thing going on, that's where the workload challenge really comes into play, because now you've almost got a role that's kind of set up to be two different people, but one person can do. And there's trade-offs. There's good things about having one person do both roles, and there's also bad things about having one person do both roles. But it's not consistent across education programs. Anything else? I'll let you guys think about this as I move on to the next part. So as I said, we went to all of the schools and we based on what they said to us, what they shared with us as what they needed, we asked them to put together a proposal and give us an idea about how much, what kind of grant that they would like to receive. We got 10 different programs. Here's just an example of some of the programs that they had. Faculty workload optimization and simulation training support. So many of our community colleges have completely revamped and upgraded their simulation centers, so many of them. But what they don't have are people on site who are trained in that simulation to be able to use that simulation center as effectively as it can be. Again, that's not consistent. What is consistent is that so many and many of the programs that we went to had brand new simulation centers that have been completely redone. Also, some structured onboarding, mentoring, and professional development for new educators. This came up again and again. This was consistent, that when they are bringing new educators in, particularly if they're recruiting them from a clinical setting, they're bringing them into this academic setting, and there's a culture shock. We heard people talk about how it was a culture shock, that they didn't understand why things were working the way they did. We also heard about imposter syndrome, where people that were in a clinical setting coming into an education setting were like, they felt like they weren't qualified to actually be educators. So that was another, so there are some grants that are specifically to building some of those mentoring and building that onboarding at their location. Targeted recruitment efforts in rural and other high needs area. This happened in a lot of our smaller community colleges that we talked to, where if they had a position open, they might put it on their website and that's it. And they really wouldn't do anything more. They would just have a job. They would just post the opening on their website. They wouldn't use any of the ways that people typically go and look for jobs anyway. They wouldn't use those outlets. They would just post it to their website. So there are, and especially in Eastern Oregon, they really needed, one of the things they needed is they needed some staff to actually be focused on that, so it wasn't falling upon the educators themselves to try to recruit their team. And then finally, wellness and team building initiatives. There were a lot of schools that had a team that was all put together, but they were all brand new and they didn't know each other. And we know from the work that we've done about recruitment and retention and embeddedness in a workplace, you do need to embed your employees into your organization and make them feel welcome and make them feel help them feel part of the team to improve that retention and morale. And we funded some projects specifically for that. Here's a couple of quotes that we got from some of the applications. So for those who can't see the screen, it says, "This project represents a critical intentional step forward in strengthening Oregon's nursing education workforce by providing part-time clinical faculty with the structure, clarity, and support needed to succeed and remain in academic roles." Another application said, "The nursing program has suffered for several years from high turnover and a small number of qualified applicants for new jobs. This project takes significant steps to address these recruitment and retention issues." I'm excited to see how these projects turn out. Some of them are going to fail spectacularly, and some of them are going to be amazing. And I am of the opinion that you learn a whole heck of a lot more from the things that fail spectacularly than the things that are successful. So I'm looking forward to some failures. Okay, and so this is what's next. We are going to continue to support these grants. Like I showed you on the timeline, this is not a one and done process. We're in this for the long haul. For the next couple of years, we are going to be supporting these grantees for the optimal success, doing what we can to make sure that we are taking care of them. We're going to release the findings from our interviews to get some of the nitty gritty and actual, comparison charts for you all to look at, so you can make sure you can check our work and see if that actually lines up with what your lived experience is. And then finally, we are in the next, I would say in the next 6 months, we're going to be convening any interested parties to inform what a statewide nurse educator project might look like. We've had some recommendations from some people already. We've got some ideas that are just kind of floating around. But at some point, we are going to be pulling together a work group to really look at, if we have this much money in Oregon and we could launch something that might be sustainable to really improve recruitment and retention of nursing educators, what could we do? And if any of you would like to be a part of that, Claire McKinley Yoder, let me know. And that's it. Does anybody have any other questions?
Well, just the process of training new nurses or nurses. There's two parts. There's that adjunct faculty or that clinical instructor, but then there's also the preceptor. Were the preceptors, did you listen or hear from nurses that also precept students at their clinical site? And are they considered adjunct faculty also?
Generally, no. Generally, preceptors are kind of following into the nurse educator and the nursing professional development role. So no, this particular project was just looking at the nurse faculty in an education setting. There might be someone in an education setting who is also precepting, and that might be someone, to your point, that might be working as a registered nurse or working as a nurse practitioner, and then precepting someone while they're also faculty. That could also happen, but really, when we're looking at preceptors, we're kind of taking the concept of preceptor out of this equation for now, just so we can really get at that nursing education piece in higher education.
Pretty applicable to lower or to ADN, BSN. But when you get into advanced practice, you don't really have a clinical instructor.
Right.
You have the preceptor. And a lot of times, are there any schools that are considering preceptors adjunct faculty, or, and what I'm speaking to is just, it seems like, at least for advanced practice nurses, sometimes it's very difficult to find clinical preceptors.
Yes.
And a lot of times, students, there's been a kind of a national trend where students are paying out of pocket outside their tuition.
Yes.
To be precepted by individuals.
Yes.
Have you guys ever looked into that? It seems like a real conflict of interest.
So we specifically at the Oregon Center for Nursing have not looked into it. I know that the National Academy of Medicine has been looking into this. They've had some workshops over the last couple of months where they're looking at not just nursing education, but all healthcare education, where they're utilizing some kind of a clinical placement or a preceptor model. And I think that for Oregon specifically, we do need to keep in mind that our number of graduate level nursing programs is extremely limited. Right now it's 2.5, 3. So the majority of the people that are getting their advanced practice or their APRN education are probably getting it from out of state and having to find that clinical placement, and that compounds the problem.
There seems to be quite a few programs that are all online. Students are finding clinical placements on their own, whether or not if they're living in Oregon, doing an online program and finding placements within their own communities.
Yes, that is true.
Do you know what percentage?
I don't know what percentage of that is. It's really hard because the data that we're looking at is pretty much the same data the data that we look at for clinical placements is actually coming from the Board of Nursing. So you have the same data that we're looking at, and trying to determine how many people are from out of state, or how many people who are living in the state of Oregon and are using one of the online programs out of state and trying to get clinical placements here. That's a really hard number to capture.
And if I could just interject for a second. So, well, one, thank you for coming at the beginning before all of the research is put together. 'Cause we had a conversation about how I really wanted the board to know where where the Oregon Center of Nursing was at on this, and then, you know, come back when everything is final. But I do think, just like in everything, as you all are asking questions to OCN, our policy analysts are over here, and I are thinking, what can we bring forward the next time we're here to maybe answer some of the questions? So just know we're keeping note of that.
And then the other thing is that I know that's a national problem for, and I think that this is part of it, just retaining and recruiting adjunct faculty. But it seems like what we see a lot coming to the board, if a new program wants to come on, or just a challenge with getting students clinical placement.
Correct.
Have you guys ever, has OCN ever done a broad survey of stakeholders, of students, of clinical faculty, to really kind of examine, because you said you love, like, once you identify a problem, you really love it. Have you ever, like, really looked at it to really identify the scope of that problem and the impact it has?
The Board of Nursing put together a clinical placement survey 2015 or 2016 that we participated in. And
really
so,
a long time ago.
So it's been a really, really long time since we've looked at that. And it kind of showed what you would expect. A lot of educators are trying to get in a hospital setting. They're trying to get a day shift. They're trying to get multiple hours. They're trying to get 8 students and trying to corral 8 students even in a clinical setting where maybe they don't have 8 students worth of work that could be done during that time. That they weren't utilizing nights and weekends, that there were a lot of, there was a lot of things that were determined that I remember from that particular evaluation that we did, that there were things that nursing education could do, but there's not really an incentive for them to do it if they've already got their curriculum all planned and they kind of already know what's going to work. They don't necessarily want to go outside the norm, which I completely understand.
Right. And I think I've heard from some clinical adjuncts or clinical instructors when I've just kind of surveyed them privately in private conversations, that what attracts them to that job is the hours, not necessarily the pay. So there's no incentive to do nights, weekends.
Correct. Yep.
Okay. Well, thank you.
You're welcome. One of the things, going back to the central research question, I'll just jump back there really fast and give you all whiplash. The reason the legislature allocated $5 million for this project, and specifically it was to fund programs. It wasn't specifically to raise nurse faculty salary. $5 million was never going to be able to do that. We actually calculated it out, and it would have been we could have cut a check for every nurse faculty for about $6,000 and called it a day. But that is not, that is a one-time investment that's going to make nurse faculty really happy in 1 year, but that's not going to solve the problem. And that's kind of where OCN, we get really excited about trying to solve these really, really tough problems. So we're really looking at the reason why they allocated the $5 million was to look at growing these programs. Why do we have these shortages? Why are these openings, these persistent openings in these different parts of the state, in these different settings of the state? Why is that happening? And what we have found in our listening tour is the number and the availability of nurse faculty isn't nearly as impactful to growing a nursing education program as clinical placements, as the availability of clinical placements, and also the physical space. A lot of these community colleges have a very limited physical space to be able to educate the number of students that they need. And if they are going to be expanding to the size that a lot of employers are asking them to expand to, they just physically don't have the places to put human bodies to be able to educate them.
This I have another question, so I hope I'm not completely monopolizing the board's time here or questions, but can I just...
Oh, I'm sorry, excuse me.
More of a comment, kind of a question. So one, I always enjoy when you come and chat.
Thank you.
And talk with us. I love hearing you talk. Number two, when you said 5 million, if no one noticed in the room, I dropped my food, I made a boo-boo mistake, and I thought, and then you made the comment of, 5 million, how much can that, how quickly can that go? I see that it's 2.8 million so far, so you still do have, obviously,
Yes.
the funds to make your failures that you want to make and obviously move
Yes.
forward with that, correct?
The $2.8 million is the amount of money that's been already allocated to the nursing programs that requested it. We also have a certain amount that is allocated for OCN to actually run this program for 4 years. And then the balance of it, that's going to go to the statewide project. You're welcome.
I was actually wondering, what is your favorite project that you're seeing right now?
Of all of these that they're
Yeah.
doing? Wow, that's a really great question.
Either one that's going to fail spectacularly and be a great learning experience, or one that's going to succeed really, which one do you think is?
So the one that I'm going to be watching, because I'm not really sure about. There is one where they're doing a team building retreat where they're taking their faculty to like a weekend yoga retreat, and they could have a great time and just come back and love each other, and they could hate each other after that. I don't know. I'm excited to see how that one's going to turn out. I'm interested in the one where they're going to be hiring somebody specifically to recruit, where they're going to be hiring someone in their nursing department outside of the school to recruit somebody to see if that also is able to bring in some applicants and bring in some nurse faculty. Keep in mind, especially when we're talking about our Eastern Oregon schools, they're competing with Boise. And Boise has a lot of nursing education programs, and the faculty go back and forth between Boise, Idaho, and Ontario, Oregon, and La Grande. And so they need to be competitive. So I'm kind of interested to see how that one works out. Another one that I'm interested in is there's one where they're
Not going to answer her favorite, but
they're all great.
But I actually am excited for maybe the next one you're going to say. I want to make sure you gave an example of them. Go ahead. I appreciate why you wouldn't want to say your favorite. Was the one you just mentioned the administrative burden one?
Part of it, yeah.
Okay.
Part of it, yeah. The administrative burden one is the one that I'm excited to see how that goes. It's in one particular school where the faculty, not only are they the didactic faculty, but they also have to manage all of the student support for all of their students. So if their student suddenly has a challenge with housing or with transportation or childcare, the nursing faculty have to deal with that at this particular place. So their request was to fund a student support specialist to come and just do that student support for their students. And then that takes away the burden so that the faculty can just teach.
Yeah, I'm really excited to see how that goes, because I feel like with everything we do, whether it's clinical or academic, the administrative burden type things that get in the way of us doing our job is, I don't know if you can speak to that, Claire McKinley-Yoder, but it's overwhelming and a lot.
I just real quick I am really happy, especially for our rural programs.
Mm-hmm.
I know in some of those programs, there might be 4 or 5 faculty who teach everything. They
Yes.
do all the clinical and so that piece. And then there's actually really good research out there on mentorship, like a structured onboarding program, because it is a huge adjustment from the clinical space to the, so anyways, I feel like I really wanted to call out our rural colleagues because they are working under very significant challenges and managing everything without having that support. So anyways, thank you.
I can validate that we experienced that and we witnessed that. So yes, that is absolutely true. And I'm hoping that some of these projects can alleviate that burden for them a little bit, or if nothing, just raise awareness to what that burden is. And also what my hope is that we can come to you as a board and make some recommendations of policies that could be statewide policies that would benefit everyone instead of something that might benefit a couple of schools, but then might actually hinder some other schools. So I want to be able to give you the best information so that you can make the best decision.
Yeah, and I'll publicly state, since you asked Board Member Mitchell about the survey, and we know that it's a decade old, and there is conversations about how we can do another one. It's just, as I always mention, where does it line up in the large amount of work we're all doing, but it's still sitting there. And I was thinking once these numbers came out, some of the stuff from our policy analysts in education, that we then did that. So it's coming.
I just have that one last question, if we have time.
It's a good point to segue and to recognize Jenna Britton has open time. She's been very, very available to anyone in the past. Not to voluntold you this, but Friday morning, you're still doing those, the online?
I am still doing that.
Yeah, it's a great opportunity if you haven't done one of those yet, where you can really pick her brain or just talk about any sort of topic. I want to be mindful because we went over a lot this morning and have not addressed some of our other issues. And so I wanted to maybe squeeze in some of the time now if the analysts are ready. But it's been a really great discussion, and I appreciate your coming.
Thank you
out in
for
person.
having me.
Thank you.
Board Member Mitchell, did you want to ask your last question?
No, I have no further comment.
Okay.
Yeah, if is policy analyst Wickenhagen ready to go? You were at the top of the agenda.
Well, actually, so because of the time frame, in 10 minutes is going to be the public forum. And we have to make sure that stays 100% on track. So if there's something we can do in 10 minutes, we can. I know my permanent rulemaking we could do, but is there something else, or the National Council of State Board of Nursing opportunity? Yeah.
It's a great.
Okay. So yes, I would love to have the board members hear from Board Member Hill and Policy Analyst Laura Blackhurst about their experience with National Council of State Board of Nursing, not just the conference, but also the classes, a reminder about the classes that any of the board members can take.
I had the honor of
Mike.
I had the honor in August of attending as one of your delegates, along with Laura Blackhurst, and not being from the nursing profession, it was a really fascinating experience for me. I worked in a male-dominated field. Any conference I ever went to was all men. This was a nice mix. It was also, I worked in an industry that was not only mainly men, it was all white men. And this was a racially diverse group of people of different ages, and it was the amount of professionalism and thought that came across from these people was just so heartwarming. And it was we are very lucky here in Oregon that we have the resources we do, because I met other boards where they don't have the resources. Their meetings are all virtual. That was just like a big eye-opener for me to realize, like, our neighboring state, Washington, doesn't have the resources. And so that for in-person meetings, and I know that we made a decision earlier this year to reduce the number of virtual meetings we have, because we found that when we were doing disciplinary meetings, we really found we were more effective when we were meeting in person. And so the thought of that not being an option was just a reminder to me of how lucky we are. We had elections. I got to see the caliber of people that are serving on our national board and the thoughtfulness. There was a really, really wonderful presentation panel about advanced practice nursing that, for me, not being, as a public member, was really eye-opening, because there is a real issue. with the Council on Accreditation now requiring doctorate level for advanced placement, that has created some real challenges. And this goes along with the present, what Jonna just talked about is so consistent with what the national information was about, they're not admitting qualified applicants. Big part of that is insufficient faculty and insufficient clinical sites. And then they had this thing about, and this came from the National Organization of Nurse Practitioner Faculties. The shortage of faculty, but no vacancies, which I found really interesting. It's because of these polled, almost 70% said that there was insufficient funds to hire new faculty. There was also 47% said there was an unwillingness of the administration to commit to additional funds for full-time positions. There was the inability to recruit faculty because of competition, and then also the unavailability in geographic areas. And then so this mirrors, what's going on here. But the thing that really sort of got to me was when the person came from the American College of Nurse Midwives, saying there is a shrinking obstetrical physician workforce, there's slower than needed midwifery workforce, growing maternity care deserts, which really, when we're talking about public safety, and there's significant maternal and neonatal outcome disparities. And as we've moved to this require it for doctorates, it's having a huge negative impact on our supply of midwives. And so that was something that I'm hoping we will learn more about and continue to explore. I also, I got to speak on a panel. I was asked to speak on a panel. And about what makes a good regulatory board member. They wanted to hear from someone from the public perspective because there is a thought amongst many people on nursing boards that someone from the public can't understand what we're voting on. And I took the administrative law for nursing regulators course this summer. So in conjunction to writing the speech, I was taking this course at the same time and trying to navigate all this. And in my class, there people were asking, well, how can, like if we send something to an administrative law judge, how can they understand what we're doing? And some of my things were that I don't know what I don't know. And during that course and at these meetings, I'm constantly learning that I don't know what I don't know. I got to brag on this board because the level of respect and the ability to not all agree and to have these really well thought out discussions are something that I think we do really well. And, the amount of work that we do to come up with the best solutions I am just so proud of the work we do. And people's willingness to be open to different opinions and respect those other opinions. It's really inspiring. So I was really, really grateful that I got to go to this meeting. There are various, like this presentation that is available on the NCSBN site. The course Administrative Law for Regulators that is offered by ICRS It was a very hard course for me. It was an 8-week course. I joined it 2 weeks late because a position opened up, and the instructor would say, "Oh, the course is, the assignments should take 2 hours," and I would take 8 to 10 to 12 hours. But it wasn't because I didn't understand the practice of nursing, because we're really looking at the regulations. And that's the other thing that I was able to share is what our investigators do, which is provide us, they provide us with the statutes. And that is so important. And, I shared about what would Ella say, because that's what lives in my head. And I'm sorry, as she just walked in.
It lives in all our heads.
That is a very important part. It lives in my head, and I really appreciate that we do have counsel that continues to help educate us. And we do have, just a thoughtful process. Our staff is very thoughtful about providing us with the resources we need. And then sorry, I took a lot of that time.
Before I transition to policy on Black Earth, I'll say 2 things. One, the administrative law class a few of our staff have taken, and it takes way more hours, and it's the feedback that I've asked them to give them. So I was a dropout. So I look forward to finding the time to get back in. And 2, just for the board to know, the topic around DNP and Oregon's decision and the national information will be brought forth in November, because several of you have asked us to do that in November. So we'll give a presentation on that in November for further discussion. And then you're up.
I don't have too much to add, but I will say I was really grateful for the opportunity to attend the NCSBN annual meeting and be a delegate for Oregon. I just felt like there was so much conversation and collaboration that happens at these meetings. And as policy analysts, we're always trying to bring you things that are aligning Oregon with evidence or aligning Oregon with national trends. And so these meetings are such a great opportunity to learn. Even the things you don't know that you don't know, you get into conversation with someone and learn about regulatory issues in other states. And I'm so glad, Board Member Hill, that you mentioned that you gave a presentation, because I got to watch her presentation. And I think the other thing that we really got to shine the light on Oregon about is that not just do we have a public board member, but we have a public board member in a leadership position as a president-elect. And I saw so many people coming up to you after the presentation, just so impressed that Oregon had a public member serving in that capacity and what it brought to the board and the role.
Well, it's interesting because our colleagues to the north in Canada that come to National Council State Board of Nursing, they have 5 public members on their boards. So they actually disagree strongly and feel like it's a really powerful thing. And then the fact that you just mentioned that, when I was there the year before with the past president, who's a CNA, oh boy, no one thought a CNA could hold that position. And there was an interesting kind of disrespect for that regard, and people then, of course, cheering him on. So I always love when Oregon gets to stand out in certain ways when we're at national level. But I just want to publicly thank Board Member Hill and Paul Stanislaw, our Blackhurst, for representing Oregon there. I, at the last minute, was unable to go. And on that note, what is going to be hard moving forward is states in any capacity aren't going to be able to send people to conferences anymore. There's no budget. This happened to Washington, and it's now happening to Oregon, and we'll see it to many states. But National Council actually supports 2 members every meeting to go. So it's usually the executive director and someone else, and then you can apply for more. So we'll be able to continue to go to those meetings. It's just other conferences. The governor has put out a statement that we won't be able to. So, all right, thank you.
So I wonder if we have, the next portion of our meeting should be the public forum time. I wonder if we have anyone here in person, first off, that is prepared to speak. And is there someone in the room that wanted to speak for the, I'll have to read the script, but I just want to make sure. No, it doesn't look like it. And then, is there anyone online that was wanting to speak at the public forum for the 5 minutes? Okay. Yeah.
Hello, this is Adam Wright. Are you able to hear me?
Yeah.
So we were unsure. Thank you for changing your name, and it's helpful. And thank you for joining us. And I'll pass it back over to the board president.
Great. Thanks. Let me just, I guess I'll read the introduction, though. I think we've met you before.
Yes.
Run DC instead of run DMC, huh? You have to tell me about that later. The 5 times a year, the board provides an opportunity for the public to make comments or present issues of general interest. This is not an opportunity to discuss investigations. The board will not deliberate on any issues or requests during open forum. The board president has the authority to stop an individual's comment when, in the opinion of the president, the comments go beyond this directive or as necessary for efficient and orderly conduct of this meeting. Each speaker is allowed 5 minutes to speak. If you wish to participate in open forum, please contact, this would be for next time, Brandy Ritter by 5 p.m. the day before the meeting. And so it looks like we have our one guest, Adam Wright. If you want to introduce yourself, and we'll put you on the 5-minute clock, please.
Absolutely. Thank you for your time, members of the board. My name is Adam Wright, and I am transitioning into the former dean of Portland Community College's nursing program. I'm taking this opportunity to advise the board of my experience at the college. In April of 2025, I took the difficult and necessary step of accelerating my concerns to Portland Community College regarding the deeply ingrained racial inequities I witnessed and experienced as the program dean at the nursing school. As a graduate of Portland Community College, I have dedicated my career over the last 20 years to supporting and guiding nursing students, and it was heartbreaking to acknowledge the reality of the hostile environment that had developed within PCC's nursing program. The letter I delivered to PCC detailed volumes of irrefutable evidence consistent of racist and discriminatory treatment of myself, other staff members, and nursing students, particularly those of color, which I had previously reported to my leadership on multiple occasions and to no avail. Despite the compelling evidence presented and of which leadership was already aware, PCC's response was inadequate. PCC's Human Resources and Administration team had admitted to me that within the prevailing culture, little could be done and little to nothing would be done to effect change. Ultimately, I found myself facing a painful reality. PCC was allowing and planned to continue to allow a racist working and learning environment to persist. Over the nearly 2 years as the program dean, I received countless testimonies from students who faced unfair, biased, and unlawfully discriminatory treatment in the classroom. Faculty members were openly biased, often failing students of color in ways that were not only unjust but flagrant. I witnessed faculty conspiring to alter grading rubrics in ways that intentionally disadvantaged these students, creating barriers that suffocated their academic potential. Each complaint I received from students and others painted a grim picture. Instances of humiliation occurred frequently, particularly during a 2024 pinning ceremony, a moment meant to celebrate achievements. During what should have been a celebratory and uplifting event, students were called out for their deficits, their physical attributes were criticized, and their language abilities were mocked. This disregard for their dignity was distressing, yet the college looked the other way, with no investigations materializing to hold anyone accountable despite the mounting evidence. Later, PCC's decision to promote one of the faculty members who has been the subject of many complaints of racism and discrimination and a notorious offender of professional standards only added fuel to the fire of student discontent. This faculty member's trail of complaints and grievances regarding unlawful discrimination and harassment of students and colleagues has grown dangerously long, yet the institution placed them in a position of authority as faculty department chair, the very role students are steered towards when issuing faculty concerns or complaints. It is a bleak moment that leaves me questioning the integrity of the program and the institution I had earnestly tried to uplift. I delved deeper into my analysis, and it became clear that the bottom tier of the nursing cohort, a group predominantly composed of students of color, transgender individuals, and non-native English speakers, often reflected systemic issues embedded within both the program and the college. The data underscored the pressing need for accountability and reform, yet each appeal I made for intervention seemed to vanish into thin air. In my role, I was deeply aware of the psychological harm in the environment posed to our students, and by extension, the communities they would one day serve. With every complaint left unaddressed, the risk to their emotional and professional health and safety became more acute. These months of turmoil culminated in a decision that felt like a shattering of my own ambitions. Still, ultimately, it was a necessary step towards opening a long overdue conversation about race, equity, and injustice within the nursing program at PCC. Deciding to separate employment with college was a painful decision for me, yet it opened the door to reclaiming my voice and the student's voice. It is my desire to engage the Oregon State Board of Nursing's regulatory authority and request a thorough investigation of the nursing program's culture and prevalence of racism and discrimination, ensuring that students' voices, their stories, would no longer be silenced or ignored. In my heart, what I have witnessed is a systemic issue that requires not just a change in the nursing program, but an overhaul of college policies and practices that have allowed such inequities to persist. It will be a daunting task ahead. I know I have to act, not just for our nursing students, but for the integrity of our profession itself. For the sake of the students who deserve better, I am determined to take a stand and facilitate a shift toward a more equitable future of nursing, nursing education, and the elimination of these racial inequities in our profession. It starts here, and it starts with the Oregon State Board of Nursing. I ask you kindly, please help.
Thank you, Mr. Wright, for speaking up and joining in this forum today. I'll remind that we're not allowed to deliberate nor give much response, but I'm sure you'll hear more from board staff later.
I appreciate everybody's time.
Thank you. Do we have anyone else online or in person that would like to?
Not that I'm aware of, unless anybody here behind me is signed up for, okay, and nobody else online. Just Mr. Adam Wright. If you want to take a brief break, it will give us, maybe 10 minutes, and then we'll know, no one else is coming for public forum, and we can move on with the rest of the agenda. 20? Yeah, 1:20. Is that what you said? I don't know. I'm looking at my clock in front of me. Okay, perfect. Okay.
To confirm again, we don't have anyone else that would like to speak in the public forum. This is
That's correct.
the last chance. No one signed up. All right.
Boy.
So, just some urgent coffee delivery. Keep Phil, caffeine. Keep Phil clicking. Well,
Our IT supports, the other half does not want to give public comment.
so then, so I'm going to direct. We're jumping around on the agenda here, and I'm mindful that our guests from George Fox and Carrington are still going to present on time, if not a couple minutes early. So we're mindful of your time. But I want to jump to 1:45 would be the time frame that we're at with administrative rulemaking from. Ready to go on that?
Thanks.
Page. That is page 10.
329.
But yeah, what? Oh, sorry, 329 of the.
Yeah, so we're just basically staying on track with the agenda of what we're doing after our public open forum. So I draw your attention to page 329 of your public packet. Board members respectfully request that the board approve the permanent adoption of the rulemaking in Division 1 and Division 2 to implement SB 1552 from 2024, which is now found in ORS 670.280, sub 4. And as a reminder, temporary rules were approved and became effective on July 1st, 2025 to align with the implementation date of the statute. The provisions outlined in ORS 670.280 sub 4 allow individuals to petition a licensing board before starting an educational program to decide whether a criminal conviction would impede the individual from obtaining a professional license or certificate. And today I'm requesting that the board approve the permanent adoption of the current temporary rule that went into effect on July 1st, 2025. And I will just say, when I make the motion, I will have to modify from effective October 1st, 2025 to effective September 19th, 2025.
Looks like we're ready for the motion, unless there's. Yeah, great.
I turned myself off. Members of the board, I request that you approve the permanent adoption of OAR 851-001-0111 as modified effective September 19, 2025.
Clarification question, as to the last four digits.
Oh.
Mm-hmm.
In the agenda, it has 110, but
Do we have a wrong number in the agenda?
Okay. So, yes, thank you for that clarification. When we had an amended memo compared to the agenda. So please, it's part of the modification, not just changing October 1st, 2025 to September 19th, 2025, but also it is 851-001-0111. So I can read it again, just so we're back. I say it straight up, different than from what you have. Okay. So members of the board, I request you approve the permanent adoption of OAR 851-001-0111 as modified effective September 19, 2025.
So moved.
Second.
The motion has been moved and seconded. We'll do a roll call. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Towabola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
Hey, so board members, I make a motion to approve the permanent adoption of the proposed amendments to OAR 851-002-0055, presented effective September 19th, 2025.
So moved.
Second.
It's been moved and seconded. We'll do a roll call. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Towabola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
Thank you. Give me 1 minute. All right, members of the board, I request you turn to page 372 of your board packet and respectfully request that the board approve a motion for the permanent adoption of the proposed rulemaking concerning Oregon Administrative Rule, Chapter 851, Division 002 of the Nurse Practice Act, which outlines agency fees. As a reminder, in September and November 2024, the board discussed and voted to approve a modification to OAR 851-002 licensing fees, which includes an increase of $35 for all LPN fees and $100 for RN fees. During the 2025 legislative session, the Oregon State Board of Nursing presented our budget to the Ways and Means Committee and received their approval, and the board subsequently approved these modifications as a temporary rule effective July 1st, 2025. And today I'm requesting that the board approve the permanent adoption of the current temporary rules that went into effect on July 1st, 2025. Great. So I am going to once again make it effective September 19, 2025, but read that into the motion. Board members, I make a motion that the board approves permanent adoption of the proposed amendments to OAR 851-002, 0010, 851-002-0020, 851-002-0030, and 851-002-0035 as presented, effective September 19th.
So moved.
Second.
The motion has been moved and seconded. We'll do a roll call. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
Thank you.
Is licensing manager Fox available?
He is. He's with us virtually if he wants
Great.
to. Yes.
If you're ready now, then please present your items. It looks like we're on page 387.
Yes, thank you. Board President, members of the board, please turn to page 387. I've got 2 licensing exceptions for us to go over today. Applicant Trisilla Matano received a Bachelor of Science in Nursing in 2009 from the College of the Holy Spirit in the Philippines. The transcript was received by Educational Records Evaluation Service and approved a credential evaluation service, and the education was determined to be equivalent to completing a regionally accredited institution of higher education in the United States. Applicant Matano obtained their RN license in Kenya on July 12, 2010, and their license validated with the Nursing Council of Kenya on March 30th, 2023. There is no disciplinary action indicated on their license in Kenya. Applicant Matano has been working in the United States since April of 2023 in the healthcare field and would like to challenge the NCLEX RN to move back into a career in nursing. Applicant Matano is seeking an exception to OAR 851-031-0026 sub 2. The rule states verification of practice hours must be received directly from the employer. The verification must contain the level of practice and a listing of nursing duties, the numbers of hours worked, and signed by an administrator of the facility. This letter must be presented in English. A translated copy of the original letter from an American Translator Association certified translator will be accepted as long as it is accompanied by a primary source letter in its original language. By granting an exception to this rule, applicant Matano would be allowed to challenge the NCLEX RN up to 4 times to obtain their Oregon RN license. Their statement is provided in your board packet following this memo. I'll let you take a look at that if you haven't already before making a motion.
Any thoughts or questions from other board members? Sounds like thank you for bringing this forward. It sounds like we're ready for the motion.
All right. I'd like to make a motion that based on the information presented, the board grant Trisilla Matano an exception to OAR 851-031-0026 sub 2 as presented.
So moved.
Second.
Motion has been moved and seconded. We'll do a roll call vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toobola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
All right, if we can move to page 391. I have the second licensing exception. Applicant Sega Mebratu graduated from the Sumner College in Portland, Oregon on January 29th, 2021, attending during the COVID-19 pandemic. They applied for their LPN with the Oregon State Board of Nursing and scheduled their NCLEX PN test in July of that same year. 3 days before they sat for the NCLEX PN, they received news that 2 immediate family members had passed in a car accident. They sat for the NCLEX PN, but they did not obtain a passing score. They did not attempt the NCLEX PN examination again, focusing on caring for their family as a single mother. Applicant Mebratu is seeking an exception to OAR 851-031-0015 sub 3 sub A. This rule states applicants for initial licensure by examination, not previously licensed in another state or country, will be permitted to test no more than 2 years following program graduation. By granting an exception to this rule, applicant Sega Mebratu would be allowed to test up to 4 times to obtain their Oregon practical nurse license. Their statement is provided in your board packet following this memo.
Thank you for bringing this forward, Manager Fox. I think we're ready for the motion.
All right, I'd like to bring a motion that based on the information presented, the board grant Sega Mebratu an exception to OAR 851-031-0015 sub 3 sub A as presented.
So moved.
Second.
Motion has been moved and seconded. We'll do a roll call vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toobola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
Thank you.
Thank you. The next item on our working ahead agenda here is, I believe we have the representatives from George Fox,
I will.
right, or Carrington?
Present.
Should we, which?
All right, my first item for the board is on page 395 of the packet, and this is in regards to a proposal to update the program outcomes of the pre-licensure nursing program at George Fox University. And we are joined online by Dr. Pam Pfeiffer. She's just turned on her camera for us. As noted in this memo, George Fox University is updating their program outcomes to align with the American Association of Colleges of Nursing's Essentials, which establishes core competencies for baccalaureate education. And the program has also submitted this notification to their accrediting body. So I am happy to answer any questions regarding their proposed changes. All right, I'm happy to bring a motion. Then I motion that George Fox University's pre-licensure registered nursing education program outcomes be approved as presented.
So moved.
Second.
Motion has been moved and seconded. We'll do a roll call vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toobola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion passes.
All right, thank you so much. Then my second item can be found on page 402 of the packet. This memo is regarding Carrington College's application for the initial approval of admissions of students. And we are joined by 3 guests regarding this proposal today. So we have their dean, their associate provost, and a faculty member from the program. As I noted in this memo, this is step 2 in the new program approval process, and I've aimed to highlight in the memo the key areas in their application. The application contained all required information per OAR 851-021-0010-2, and their associate degree program would begin prereq coursework in February 2026 with the nursing coursework beginning September 2026. I'm happy to answer any questions on this item.
Policy Analyst Blackhurst, I just had one question. Because this is being submitted a year in advance and our statutes say within 6 months we need the nurse faculty outline, will they be resubmitting a report to us, or I just was wondering about the process for that?
Thanks, Board Member McKinley Yoder. There's not a specific process outlined in the rule to request a resubmission. However, part of our routine process of surveying nursing programs is that we survey once a year to get a list of all current faculty. So that would occur in about 6 months. Any other questions? Okay. All right, I'll bring a motion for this one. I motion that Carrington College's application for initial approval of admission of students be approved as presented.
So moved.
Second.
Motion has been moved and seconded. We'll do a roll call vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Felipe Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion passes.
I think at this point, we're going to wheel back in time as if it were 11 o'clock and enter into some administrative rulemaking from our policy analysts.
Page.
So that's page 73 was the first one. If we're going to follow the order here, we could start with Dr. Wickenhagen's proposed revisions.
And members of the board and any public watching, we will be starting with a presentation. I am going to kick us off today, really priming you all for the work that the OSBN policy analysts are bringing forward. They really did something huge, and I really wanted to highlight it before they start discussing it. I really wish the opportunity that my, Chief of Staff, Legislative Director, and the policy analysts took to really dig into our statutes is something that all agencies did, because I think it's going to pay off tenfold. We're going to present a very high-level overview of the changes, and then take questions on each division once the presentation is complete. So again, I have the honor of starting us off. We want to go to the next slide. All right. So I just want to do a real look back of 3044, which was OSBN's bill to update statutes that make up the Nurse Practice Act. Like many statutes, they were developed and modified over decades, leading to a patchwork of laws and rules, some of which didn't reflect current nursing standards or practices. The bill itself is focused on 3 high-level buckets: alignment of statute, removal of barriers, and modernization that reflects the current nursing practice and understandings. So the policy analysts will be discussing the changes in greater detail, but I just want to call out a couple from each of these buckets. We're supposed to be on slide 3, so I don't know if that is 2 or 3, just to be clear. Okay, great. So as staff moved to review the statute, we saw a few places where there were inconsistencies within the statute itself, and we needed to seek alignment. So for example, ORS 678.031 and 034, the statutes overseeing exceptions were misaligned, one allowing for non-resident nurses to use the exception, and the other allowing for both non-resident and previously licensed applicants to use the exception. So HB 3044 clarified that previously licensed applications were permissible under both statutes. And looking to remove barriers for our applicants, licensees and certificate holders It's been a focus for OSBN during my tenure, and we reviewed our statutes with that in mind. And one of the best examples of improving customer service include being able to issue refunds when appropriate. House Bill 3044 updated our statute to ensure applicants may receive a refund when appropriate. And finally, House Bill 3044 sought to modernize language and reflect nursing practice as it is understood today. This included language updates, such as updating language from chemical dependencies to substance use disorder. Next slide. I'm going to kick us off with just presenting on one division. So Division 1 sets the foundation for how the board operates. We've modernized procedures for clarity and reduced redundancy. And the key takeaways is this division doesn't change practice, but it makes these rules clearer and easier to follow for the public and licensees. The goal was modernization and clarity. Again, no changes in practice, but just being more clear, more accessible framework for licensees and the public. And I'm just going to give a few of these details of what was addressed. So in 0009, the civil penalty rule, by changing is to may, we updated the rule to both align with statute and allow for board flexibility in assessing civil penalties. We also removed antiquated references to certificates from when APRNs were issued a certificate rather than a license. In 0015, we added disciplinary throughout the rule to reflect changes later in the NPA that you'll hear about. In 0100, updates to allow for nursing professionals to renew up to 90 days post-expiration without civil penalty and update statutory authority, which I know I'm sure we'll have a discussion on. And 0111 added certificate holders. And 0170 updates patient to client throughout to reflect modern language and update statutory authority. And at this point in the presentation, I'm happy to turn it over to policy analyst Dr. Wickenhagen. And next slide. We'll make the motions at the end for everything.
President Cooksey, members of the board, the policy analyst board staff have drafted potential administrative rule changes to, again, just as Executive Director Prusak mentioned, alignment with enrolled House Bill 3044 to correct OER citations and update terminology. In Division 2, agency fees, what it includes is, again, language cleanup, such as explicitly stating that fees may in fact be refundable. There are no adjusted fees other than what Executive Director Prusak has mentioned to the board, and those are permanent rules, and they're separate from the changes, the grammatical changes that we have made here. Are there any questions in regards to Division 2?
And I appreciate Dr. Wickenhagen, you mentioning that, because I think I should ask the board, do you want to do, because it is such a huge body of work, division by division, discussion and memo, and then make the motion because it's such a huge body of work? At first, I was thinking the other way, but now as we're moving through it, I think it might be better for you all to be able to take it. Okay. So then should we go back to Division 1? Okay. Yeah.
Director Prusak?
Yes.
I have a question on Division 1 language. Now I have to go back, highlight it. Under the imposition of civil penalties, subsection 3 says a civil penalty of a minimum $500 to a maximum of $5,000 per violation is assessed for any of the following. And so that, again, was that looked at?
Well, Board Member Hill, that is in our statute.
Okay, so
that is, there's no changes in the numbers, no. It's much more around the flexibility, adding flexibility for you all. And then,
yeah, we could change to may, but that's a board discussion.
So, because I don't know that we've done this, I think that's my question. So that sort of goes to my question. you know, are we doing this for when we have the findings that these are the violations that we're disciplining for?
Couple thoughts. Sorry.
I'm going to lean on my legislative director, who's been in the weeds with the policy analysts for me, and then when you're in their divisions with them, our policy analysts, because the way I'm about to answer is that's the question here, is changing it to May. But go ahead and.
Right, so I think that was addressed in sub 2, and it may have just been missed in sub 3, is what I'm thinking.
Okay.
And so, yeah, I think that what we could do is a civil penalty of a minimum of 500 to a maximum of 5,000 per violation may be assessed. And would that work?
So what we did in one, we didn't do in the
Right, so we would modify. sub 3.
Absolutely. Because I want it to be consistent with our
Right.
practices.
I think it was just a miss.
Remind me one more time.
851-001-0009 sub 3. And it would read a civil penalty of a minimum 500 to a maximum 5,000 per violation. And we'd cross out is and add may be assessed. So, and then may be. Yeah.
Thank you.
Yeah, no, thank you.
Okay, are you still?
Any other questions?
Okay, mine is on page 92, and this might just be a clarity question because I think we'd mentioned yesterday that we're going to talk about it today. It's 851-001-0010, subsection 3. The executive director or designee may sign a stipulated order for civil penalties levied due to reinstatement of a license when the licensee or certificate holder continues to practice nursing or see any authorized duties for more than 90 days. And I just wanted to get clarity on that 90 days.
Right. Thank you for asking. I know it's on the mind of your fellow colleague board members. So as mentioned, since arriving, really wanted to align not just our rules with our statutes, our internal policies with our rules and our statutes, but also national trends. And when we have these discussions in our executive sessions, I felt like there was an opportunity there to really clarify the work that we're doing. And so I'm proposing 90 days. And the reason why I'm proposing that is after looking at the national trend, we have jurisdictions that do 30 days, 60 days, 90 days, 6 months, 12 months, no civil penalty in many jurisdictions. And so was kind of looking at the median, the average, and then bringing that to you all to discuss, is 90 days the appropriate number of days that meets the threshold where somebody who forgot to renew their license goes over to the investigation department. And I think that's the discussion of what you all land on today, but based on national trend and all of the other things we talk about of investigation and what does it mean to have discipline of the civil penalty on your license in perpetuity for, yes, it's quoted as practicing without a license, but it's often forgetting, to renew your license. Now, of course, if there's other reasons that come along with not renewing your license, like any type of other complaint, that's a very different process, right? But when does a licensing department send it over to investigation? What is the threshold for that?
So just to make it a little complicated, so the question here is for the threshold of 90 days, but also to clarify, is this saying that if it meets the threshold of 90 days, this is delegating authority to levy the civil penalty before it comes to us?
Absolutely not.
Thank you.
I apologize that I answered a completely different question, but I know that it was coming, so for discussion.
I'm trying to understand why we would allow unlicensed practice for 90 days. Why is any amount okay?
This is this is a renewal. This isn't an initial, right? So I think about it as you have a nurse practicing for, as often is the case in a lot of these, 20 years, 25 years, for all intents and purposes. I mean, they have the skill set, they have the knowledge and the capacity to provide that. This feels more along the lines of a clerical issue where life happens, people are on medical leave, and they miss that renewal. It's not excusable. There is still a late fee that is invoked at that time. I think the difference in my mind is lowering that permanent mark that is not expungible for 1 million years on their record. You know, when we look at my great-great-grandfather, Marcus Cooksey, who didn't renew in 2027, he's still got that on his record just for showing up, 62 days, or remembering to do it 62 days late. So I think it's distinguishing, really. I share with you that belief that the intention of the law is that people are practicing as adept and capable and qualified nurses. I think this is giving that little bit of leeway in there. And as Executive Director Prusak spoke, like even with if there is any other practice concerns, that would be elevated immediately. That would be elevated and investigated.
That would be a very different situation.
I share that, a lot of that sentiment, but I think we've had a lot with inconsistencies of how do we apply and draw a line. This is like kind of a lot of some of the other board members have said, like, can we have some consistency? And I think I like the suggestion of 90 days. I think that's, but I'm open to what people feel is the like threshold that we say, okay, you've crossed into civil penalty, not just a late fee.
I'm personally okay with the 90 days. I think on this specific, then my clarity question was because it falls under the delegation of signature authority. Like the way it's framed, that sentence seems like it could be signed off on before it comes to the board versus it comes to the board and then it goes back. Just because it's under the delegation of signature authority. And I don't know if I'm just reading it wrongly, but I'm fine with 90 days. It's a threshold of like, if life is really going on within 90 days, I really hope life settles out for you.
Well, just a point back on that. I believe it's 90 days we send the email, right? To remind somebody 90 days in advance.
Yeah, so the reason why you were all seeing many of the practicing without a license the first year I was here is there was a change when we changed to a different system, and the 30, 60, 90 days reminders weren't there, and we heard from many angry people. Since reinstituting that, we have way less people forgetting, okay? 100%. So they get a 30, 60, 90. I just got my 90-day renewal. I have not renewed it, but I got it. I will get a 60-day renewal. I will get a 30-day renewal, and I will renew on time. But if for some reason I didn't, 1 second after midnight, I get a delinquent fee, and then anything after that, there's now going to be a process for late renewal. And to the delegation question specifically, because I need my whole team of brains to help me with mine, we can align that with the other discussion we're happening. When we come back in November, so everything is aligned so that here it says it and it says it everywhere else. Yeah, that's the goal.
I'm comfortable with 30 days. Is everybody else comfortable with 90?
So I just have a question. I thought I had it straight until Nikki made her point. So I just I get the whole 30, 60, 90, and then what you're saying is at 90 days, we wouldn't even see this before us until, correct?
Yeah, let me explain the process and then have you back me up if needed. What I'm trying to do with this is look at the national trend and say, where does it meet the threshold for an investigation for discipline? When the licensed team says, absolutely not, this is not a late renewal anymore, where you get your $100 delinquent fee. This becomes an investigation, and it will have discipline because civil penalty is discipline, and this is how we treat these. So is that threshold for an investigation 30 days, 60 days, 90 days, 1 year? That is up for debate across this nation. Many people do it 30, 60, 90, 1 year. I thought the mean when you add it all up of the information we got was 60 days. That is what I want to align here, what meets the threshold. And I'll just say one more thing for you all to think about. When we have discussions around discipline and we find no public harm and things get dismissed, I think about that sometimes here. No public harm, we see some things get dismissed. There was accountability, there was discussion. So I just wanted to have that discussion about where does this fit into that? Because right now it hasn't. Right now they get discipline. And this is a big conversation if anybody is following it in Kansas. And actually when policy analysts and I asked to do a national survey through National Council State Board of Nursing on this, when the Kansas Board of Nursing saw us asking, they asked for our results because of this issue of people feeling as though the board harmed their reputation by kind of being really punitive about late renewals. So again, I trust that the board will make the right decision of what you want me to do. I wanted to come with a number of what I was gathering across the nation. But again, like everything else we do, there's no 100%. None of us are doing it standardized across the country, which can be frustrating at times. So we get to, though, have this conversation today and make that final decision. So no more is coming to you not aligned. I'm going to align our rule, our statute, our internal policy to what you feel comfortable meets the threshold for late renewal, for an investigation and discipline.
Director Prusak, sorry. So at what point in the late process do they have to resubmit fingerprints? When does that kick in?
It would be on day 91.
Okay. So this would eliminate, because my understanding that right now on day one, they would have to submit.
They would just have the
If you're doing renewal up until day 30 post expiration, you have a state-based state-based criminal background check. After that, it would go to fingerprints. Under the rules that are proposed today, you would have up to 90 days post expiration, and you could use a state-based criminal background check. On day 91, you would move to fingerprint-based.
And I think that's the other thing. This is aligning with some of the other stuff that we're doing that you'll hear in each division we talk about from the policy analysts that will connect with this number, because we're trying to get away from, again, an Oregon thing that others didn't do of reactivation, of reentry. How would we have renewal, late renewal, reinstatement, and the reinstatements are done for 2 reasons. So we're really, the work of a year of policy analysts, the work in the statutes, the work of the last couple of months to align everything, it's all coming at you today in one full swoop because we have a date that we're legislatively mandated to have these statutes go into place. But there's still some just fine points that the board gets to then dictate.
And then board members Tobola and Standish, let me see if I can maybe address your questions about some of the language in this particular rule. So my understanding is that this rule is being proposed to be revised to align with these other pieces about timelines. And I think as part of the prior discussion today about some questions about when staff can sign civil penalties, I think that question, so I would say consider aligning the timelines now so that this rule isn't consistent, but I think there's an understanding that further review into whether this particular thing is something that the board would like to discuss in the future about whether that's something they want delegated to staff is something that could be kept in mind. So I understand this particular language here might be raising some of those questions, and that's something that I believe is already on staff's radar to bring back in the future.
Just a question. So statutes are generally broad. What does the statute say exactly on this?
It doesn't. Yeah, it gives the board the discretion to do in rules.
Forward on this piece about the delegation of signature authority and invoking the civil penalties. Would other board members feel comfortable with a more mid-range number of days, like 60 days? Or is it really, is that
Something less would help me. I mean, 90 days is a quarter of a year. And you guys, the board is reminding people at 90 days before, so now you're looking at 180 days. That's a lot.
Yeah, and I think, but actually, I'm just going to let you.
what feels right for you then? Is it the 30 days?
I mean, 30 days feels reasonable, right? Like maybe there's some crazy thing going on in your life, but you still got a month to pull yourself together and do that renewal.
When I'm looking at this, I'm seeing that they're still late, though. They still get that late fee. So they get, on day 91, the fee, they have 3 months, they're still assessed that fee. Only on day 91, that's when it turns into something else.
Additionally, their employers, if they find out, will not allow them to work until they get that renewed. So they already have 2 consequences. I mean, it's not like they're living without consequences for a late renewal.
I agree.
Yeah.
I think that she showed us that she did enough research that that's kind of like the median for me personally. And like he said, my job does say no after one day you don't get to. Sorry, that's just how it works. There is the fees that we have to pay as well. But I think that it's so that it's there just in case, not that they're saying it's okay. And so for me, the 90 days just sat well with me.
I agree. 90 days, kind of the threshold. Number 2, it's not like there's not going to be some late fee, but the thing that I guess I struggle with is some people that have been nurses for 20-some years and that just one-off happens. This isn't people that it's licensees that, oh my gosh, here's another time they went to go renew. It is clearly that mistake, and they've been acting as a nurse for 20-some years, and this just one incident happened. God forbid it ever happens to me. I have an entire week blotted off in my calendar, and I do, and I can show you, but it could still happen to me. Maybe my phone goes, maybe the calendar goes bye-bye. I appreciate all the warnings but I think 90 days is still sufficient in my understanding of what would be able to be acceptable.
I agree. I'll give you an example. I had a court date and I am very OCD with my phone, alerts, alarms, all the things. And I could not believe I forgot a court date. I'm like the rule follower. So I'm just saying there is life things that happen to people. And I feel like that's just kind of what this is. Not that people are out there to break the rule.
And I just want to make sure that I was clear because I know that I'm having a difficult time this afternoon after yesterday and the week that I've had, but that anything else that happens, any type of complaint, any type of harm would never be, it stops all of that.
As someone who travels extensively at times, I appreciate the thought of 90 days because life does happen and the technology doesn't work sometimes. So I am fine with the 90 days.
So I have a question that is related to this, but unfortunately is in another section. I noticed so for me, it's on page 199, talking about the renewal of license. Are we keeping the birthday expiration date?
So, and this is where I was thinking we needed to do the whole presentation because things will start to, because what happens is throughout this, where we updated our statutes and now updating our rules, it crosses 11 divisions of things that needed to be updated. And we have been sitting in what I've been calling the 3044 war room for months now. And they've all been working so hard to find everything, to align everything. And I am just so ecstatic that I'm not trying to hit you, I'm sorry, I'm just passionate. We're actually going to have statutes that do that and rules that do that, and wish every agency could do that. And like, I'm just so I, again, though, appreciate that there's so many questions because you all deserve to know and should know. But throughout every division, this touches 11 divisions, which I don't know if any board, since you all have been here, has come with this body of work, but here we are.
So would it make sense for us process-wise to present, discuss, and then do all the votes at the end?
We could do that.
But do you want to clarify?
Yeah, and to answer your question, yes. What we found was that we had based upon the way that our statute was written, it required if your birthday happened to be in an odd year, you had to you renewed on your birthday in an odd year.
Yeah.
And what we had were some people that were getting licensed, and 7 months later, their odd year birthday came up. And so how would we handle that, right? What they were doing is, going through and trying to figure out the best way forward. It wasn't always the most equitable. So what we are trying to do is get to a place where people have a full 2 years, and we recognize that the statute, when they rewrote it, we might want to go back for some more tweaks. That won't be for another 1.5 years. That's the earliest that we can do that. But we're trying to get to equity for anyone who's licensed or as a certificate holder with OSBN.
And just like we survey all the boards across the nation when we ask questions, I surveyed all the boards within Oregon on how they made it equitable, and most people gave up. If they were able to do it because they have a smaller number of licensees, they did it by prorating, and it's not something we'd ever be able to do. But yeah, depending on when your birthday is, on your first renewal, depends on if you actually have a year, 1.5 years, 2 years. And so we heard discussions around that. So this was our answer to that, and it was debated for hours and hours and days of how we were going to get there.
I had highlighted that same area. I think that putting these two together, with the idea of the two, because we're going to have another big learning curve. If people have been used to, 15 days before my birthday every other year, I know I'm going to have to, we're going to have this whole new learning curve. So I think that, having that 90-day window could really offset some of the potential growing pains of this change, which I agree is probably a very good change towards equity.
Yeah, and I agree. We're going to have a very robust communications plan that goes out to all of our, communities. Additionally, anyone who's already established is going to maintain their birthday, which will, so again, we're going to have to lean on our comms and really communicating well, having reestablished the 30, 60, 90 warnings, having all of that in place is going to be essential, but with the goal that everyone is being treated fairly and getting their full 2 years.
This is to complicate issues for disclosure. The way our system works is send the 90, 60, 30 days warning. Would it hypothetically work to send the 30, 60, 90 days post also? That you're now 30 days late, you're 60 days late.
I think we could probably work with our IT team to make that a possibility, yeah. We can look into it.
I'm fine with 90 days.
The majority would be in favor of the 90 days change to that, as shown. Would you all prefer that we, like process-wise, we just vote each one? Okay, each division. as we go. Okay, that is the preference then.
So, do we want to have me make a motion for Division 1 and move forward? And it will be as modified, given, the additional May that we missed. Okay. Board members, I make a motion that the board approve initiating the rulemaking process by providing notice and opportunity for public comment and holding an administrative rule hearing on the proposed amendments to OAR 851-001-009015, 0100, 011, 0115, 0122, and 0170 as modified.
Clarification, after 0100, what number do you have?
0111.
Okay, thank you.
Mm-hmm.
So moved.
Second.
Motion has been moved and seconded. We'll do a roll call vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
Thank you. I will pass it back over to Dr. Sarah Wickenhagen for Division 2.
Okay, here we go. Division 2, slide back up there for you all. So we touched 7 rules in this rule section. Again, alignment with statute, antiquated language, certificate to license, category to population focus, and we removed re-entry and inserted reactivation. As I indicated before, there are no increase in fees. This is all alignment and grammatical cleanup of the division, and I'm happy to answer any questions that you might have of me for Division 2. Okay, I would propose to bring, oh, is there a question? Okay, I would like to propose to make a motion to the board that they approve initiating the rulemaking process by providing notice and opportunity for public comment and holding an administrative hearing on the proposed amendments to 851-002-0000, 0010, 0020, 0030, 0035, 0040, and 0050 as modified.
So moved.
Second.
Motion has been moved and seconded. We'll do a roll call vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion passes.
I will now pass this over to policy analyst Gretchen Cook.
Thank you. Board President, board members, before you now is Division 6 proposed amendments. This is the chapter that has the definitions of terms used throughout the other divisions of the Practice Act. So the focus of the proposed revisions in this rule focus around removing outdated terms, removing terms that are no longer used in any of the other Chapter 851 divisions, as well as consolidating all the divisions under one rule number. A notable addition I wanted to pull out because this one transcends the rest of the drafts, and that is the inclusion and definition of the term healthcare provider. So you've likely noted this term in the other drafts that you've been reviewing, and in most instances, the usage of the term healthcare provider is going to replace the obsolete proposed term of licensed independent practitioner. The difference between the two is that healthcare provider is inclusive of the physician associate, whereas a licensed independent practitioner, PAs are not independent. So that is the difference between those two terms that you're going to find. So overall, the revisions just clean up the division. I think they improve readability, and then it provides one uniform location where all definitions are in order. So are there any questions about specific terms or amendments in these proposed rules?
I had a question. I saw that continuing education was removed. Can you share some light on that?
It's a commonly understood term. We don't use it differently than it would be used in any dictionary. So
Thank you.
thank you for that question.
Will the motion be as modified?
Yes, thank you, as modified.
I just want to let.
For clarification purposes, why is that one modified?
Because, thank you, under, yikes, I'm looking at a clean copy, and I am looking on page 3 on the bottom, not the board packet numbers, and it's in relation to the definition of the term public discipline, and it's a couple of sentences, and at the end of that, the word met is not there. So it makes it read that blah, to get that, page 116. So it adds the term met.
And so to let you all know, normally I take up all this time with my little nits, and we met this morning.
So perfect. So
Yeah.
I was
Yes. Yes.
So can I assume that as anybody who's presenting something and we say as modified, it's clear for the record that it's because it's a discussion about a Scribner error for Board Member Hill? Thank you.
I did have a question. I see that we have defined licensee, but I don't think I caught anything for certificate holder or CNA/CMA. But we are using those terms. Do we need to include certificate holder? Or did I totally miss it? Broadly speaking, the way those terms are used respectively in the 61, 62, 63, they're very self-explanatory.
Okay.
Statutes do define the term nursing assistant medication aid.
Okay.
The implication of having that individual be certified.
Okay.
Somewhat self-explanatory.
Okay. Just want to make sure.
Yeah, thank you. Okay. So are we ready for a motion? Okay. So the motion is that the board approves initiating the rulemaking process by providing notice and opportunity for public comment and holding an administrative rule hearing on the proposed amendments of OAR 851-006-0011 as modified.
So moved.
Second.
The motion has been moved and seconded. We'll do a roll call vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toobola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion passes.
Thank you. And I have a second motion.
Can I, just to clarify for the record, was that on the adoption of the rule or the amendment of a rule?
Oh, I'm sorry. Thank you. The adoption.
Does that change, can we redo the vote? Just
Yeah,
to
I'll do
clarify
that.
it's
Okay.
adoption instead of
I
amendment?
had adoption in my, and then I thought I'd had the wrong word in there, so I apologize.
Is that a
That's
new
a totally new rule number.
So let's
Take all those out.
Thank you.
Sorry about that. So, new motion, that the board approves initiating rulemaking process for providing notice and opportunity for public comment and holding administrative rule hearing on the adoption of OAR 851-006-0011 as modified.
So moved.
Second.
Motion has been moved and seconded. We'll do a roll call vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toobola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion passes.
Okay. And the second motion is the board approves initiating the rulemaking process by providing notice and opportunity for public comment and holding an administrative rule hearing on the proposed repeal of OAR 851-006, rule numbers 0010, 0020, 0030, 0040, 0050, 0060, 0080, 0090, 0120, 0130, 0140, 0150, 0160, 0180, 0190, 0200, and 0210 as presented.
So moved.
Second.
Motion has been moved and seconded. We'll do a roll call vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toobola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion passes.
All right, Mr. President, members of the board, I'm going to move us to Division 21, which is our standards for the approval of nursing education programs. Now, within this division, we have updated terminology, again, replacing the term licensed independent provider and putting in healthcare provider. It was only used in 2 instances in Division 21, and so where you could find it is in the identification of who could precept APRN students. We sort of restructured the sentence to make it more simply fall under healthcare provider. And then there was actually a reference in the practical nursing program curriculum description as a provider who could direct the LPN scope of practice, or the LPN practice. And that was it for Division 21. No, can I bring a motion? Okay. I motion the board approves initiating the rulemaking process by providing notice and opportunity for public comment and holding an administrative rule hearing on the proposed amendments to OAR 851, 021, 0045, and 0050 as presented.
So moved.
Second.
Motion has been moved and seconded. We'll do a roll call vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion passes.
I will hand it back to Dr. Sarah Wickenhagen.
Mr. President, members of the board, if you can turn to page 175 of your packet, it has the associated motions, clean copy, and track changes for Division 31. This was our most extensive major update. It consolidates all LPN, RN, and APRN licensure requirements into one comprehensive division. Also clarified processes in regards to all different types of licensure: initial, renewal, reinstatement, and retirement. It also brings forward the RAC's recommendation last year for a shift to continuing education competency models, and it moves solely from practice to continuing education for renewal, which is also in alignment with HB 3044, National Standards for Flexibility, and Public Safety. If adopted, this would take place for renewal in January 1st of 2028. With that, will require significant communications, again, on our part to all of our licensees, with a 2-year window to make that effective. We also have a number there on the slide that indicates that 93% of all jurisdictions in the country use continuing education as their marker of competency in their state and jurisdiction. Are there any questions in regards to what I have just described? We do have an additional slide for Division 31. And I will pass this over to my colleague, Laura Blackhurst.
So within Division 31, we've also updated the NCLEX pathway for what happens after an applicant has failed the NCLEX 4 times. The current language in Division 31 directs the applicant to repeat nursing school, which is a significant barrier and not always feasible, both in terms of the ability of a school to issue a degree already awarded and in terms of financial aid. So the proposed rule language would allow further NCLEX attempts only after meeting remediation requirements. The applicant could either complete an NCLEX prep course or complete an individualized plan of study, which is based on their NCLEX results that are outlined in the candidate performance report provided after each unsuccessful attempt. So this policy was aimed to ensure that applicants were supported and able to meet the minimum competency requirements, while again aligning us with some of the national regulatory trends and allowing flexibility for applicants.
Okay. If there are no further questions, I have 3. There are questions.
Yes, there are.
Let's go.
Is there any language here that allows for English language proficiency testing for foreign educated nurses?
We ask for a credential evaluation, and we do not specify an English language comprehensive requirement within that, but oftentimes that is the expectation of the credentialing agency. that they would evaluate those competencies and their ability and their education to be comparative to education in the U.S.
And then I have a question on old test scores. On page 189. So if you had an applicant who, I mean, probably an older nurse, but nonetheless took the test prior to the NCLEX, and I see this language has been removed. So if someone wanted to endorse in, how does that work in Oregon?
So we absolutely have the ability for legacy nurses who have been licensed in a different format to be licensed and endorsed in Oregon.
Okay, so, but you don't feel like you need this language on scores of the day, or?
No. We modified the education section of this division in regards to removing barriers, not looking at legacy nurses. This is more of initial licensure type situations because it refers back to the NCLEX exam. And when it's my understanding that when nurses apply, they either have an NCLEX code or they do not, or they would like to challenge and receive an NCLEX code. And so we decided to go with that language, which we thought was more representative of U.S. and international applicants and drives the point without having 6 sections, which identify different countries and different criteria. It seemed very repetitive. And so we were able to consolidate all of those exam previous paragraphs into the one. And then we have a specific paragraph for endorsement. And an endorsement would be those nurses that are legacy nurses who are licensed potentially in another state. So we would just take their license from that state, review their transcripts, and we would endorse them.
And if I can just add one thing, is the exception process that we have
Right, that is
and
filled
have
in as
seen.
well.
Mhm.
Can you repeat what you had said about the difference between CMEs and continuing competency? I just didn't quite catch that.
Sure. So specifically, if we can go back to that slide, I believe the section is 0008. And I don't know what rule or what page that is in the packet. So
190.
forgive me, 190.
Yeah.
We have very specific parameters for nurses starting in January 2028 that we will ask them on their renewal if they have 20 hours of continuing education. We have it broken down in that section as well that advanced practice nurses can utilize their national certification CE towards this requirement. So it's not an additional amount of CE. This number is inclusive of their pain and their cultural competency hours as well. And then if we would have an applicant who has gone beyond 2 years, we have a window up to past 5 years of the amount of CE that we would then require them to obtain and attest to before licensure.
Great, thank you.
You're welcome.
Can I just clarify that there's no longer any practice hour requirement? Is that what I'm seeing?
Yes, you can.
Why was that removed?
Based on the Rules Advisory Committee that we had last year, there was a profound interest in moving towards that method of competency. As I indicated also on this slide, that 93% of the country uses the same method. We have previously used the same method of competency for advanced practice nurses for a long time, right? We require them to maintain their national certification, and because of that, we consider that competency. So it isn't a shift per se, it's just adding in LPNs and RNs to the same process that we allowed advanced practice nurses to do.
And I will add most likely, definitely a discrepancy in interpretation if it was ever in our statutes. Our statutes have always said CE.
I think that we had, we're really looking to modernize and align what's happening across the nation and what we can anticipate all everywhere else. That would be the biggest reason. Additionally, I will point out, CE is a lot easier to review. There's documentation for that. Practice hours are very challenging. This will help our staff be able to do what we're actually asking them to do.
So essentially, you could eliminate the need for reentry programs because people could essentially just keep up with their renewing their license and CE, take a 10-year break from practice, and never have to, and then could go back to practice because they'd have an active license still.
Okay. Board Member Mitchell, understanding the climate that we live in and also clinical placements, reentry with a required practice hour requirement is very significant. It's difficult for nursing programs to obtain those clinical placements, and it's incredibly onerous for someone who's been out of practice for a few years to get back into practice by getting practice. It's sort of a catch-22 that we find those nurses in. With this model, they'll be able to complete new competencies, new education, and then their employers can train them in whatever prospective roles that they would like them to fulfill and gets them into the job market much quicker.
Do you think that this potentially poses greater risk to the public, though?
I do not believe that this is a public safety risk at all, as it is the way that we've previously addressed competency before for advanced practice nurses, and 93% of the country uses the same model. And when we look at areas of discipline within our nurses and where they make errors, it isn't a relationship that you can align with the number of hours they worked or didn't work.
I think that policy analyst Blackhurst can add too.
Yes, I can also add that when we did an analysis of reentry several months ago, that what Oregon was doing in terms of reentry didn't really align with the rest of the country, and there wasn't really strong evidence of necessarily the efficacy or the safety of reentry in the manner we had prescribed it versus some other states. When you look nationally, reentry isn't even consistently an option. And in states that do have reentry, it looked very different than how we did it, including reentry being more focused on like resume building, cover letter building, really helping people re-enter the profession, not necessarily a rehash of your theoretical knowledge or skills. And so this is, again, a step to align Oregon with what we see other states doing.
I would like to share an anecdotal story that I got, when I tell friends I'm on the Oregon State Board of Nursing, and many of them work in the nursing profession, and they had said to me, I think it is really odd that we don't have a continuing ed requirement here in this state. And the one person shared with me, she says, I work with a nurse that's been a nurse for 30, 40 years and has had no continuing education for 30 or 40 years, so has no awareness of all of the advances that have occurred in those 30 or 40 years. So I think that this is really important, that we continue to engage people and require them to stay up to date in some manner educationally.
And I just want to add, I've been like high level watching all their really deep work, but the thing that stood out to me here was we wanted to not only do a survey and collect data on all of this, but it was also, well, how many hours does that make? And how do we make sure we're not just coming up with a number? And hence why we were able to create a number based on that data and based on survey of other states around us.
I just wanted to say thank you for this. It's sometimes hard to grasp how many people this affects. I once knew a nurse, I still know her, it made me feel comfortable and welcome in Oregon, but she developed a an issue health-wise and had to be off practice. And she's been off practice, but she's still the same one that mentors people in different states. And she's always wondering, like, I'm just going to lose my nursing license because I can't practice again. And I can't teach online because I have limitation. I have a trach. I can't talk often. So all those things, this helps that people like that can still be impactful for others and mentor, even if they can't talk at the time that they're in their situations. So this is really helpful for people like that. So I really appreciate this.
I have a question. Well, a comment and a question. I work with administrators and non-clinical that have more CEUs than me right now. So I love this. My question, though, is I'm going to block off my calendar and my phone pretty soon for 2028, because that's when I'll be renewed. Are you going to accept, which there's lots of places you can get these CEUs, and they're wasted in my world because I can't apply them anywhere. When would that start? On January 1st, that I'm going to go and get those CEUs, so everything like even in December of 20, forget, right?
Right. So we have language in Division 31 that asks that when you attest to your licensure, that the 2 years previous that you obtained 20 hours. So you look backwards 2 years from when you licensed. So for most people, it's their birthday, 2 years back. So we are hoping that people as early as 2026 get the message from us in our strong communication plan that we're moving to the CE model versus the practice hour model.
And most people actually need CEs for certification renewal already. So you're just learning to move those together and use it at the same time.
Will applicants attest to achieving those 20 hours, or will they actually be uploading course certificates?
They will attest to those hours, which is what we do now for practice. In the event that there's an audit, we would then potentially seek those documentation.
Yeah, thank you for that. The goal is, once we have this set up, is to make sure we have also a standardized audit in place. That is very challenging to do currently with clinical hours, and it lands sometimes in investigations and all of that.
Do these CEs need to be within their area of practice, or can they do CEs in wherever they want to go, wherever they want to be? And along with that, do they have to be CEs, or can they just be like, I remember when I first started working in Oregon, I had to attest that I had part of what could count as CEs was me reading journal articles, and that counted without like an official, was it ANCC CE designation?
Great question. So in regards to what counts, currently we get asked that often in regards to practice, but also CE, despite us actually having any marker for CE. And what we do is we point all the licensing questions that ask those of us back to their national certification organizations and to their employer, because they often have a list of what is acceptable and what is not. And then that could change potentially in the future when we get into an audit process. But as of now, we don't have a list of yes and a list of no. But I would say the industry standard is, in fact, that it is an accredited education and training. We do have language in Division 31 to answer your first question that does say your specific area of practice.
Okay, and I guess so I thought we were doing this thing where we were like, this is really great. You know, people can get their practice hours met through like caring for a family member when they may not be able to work in a, you know, like they're still doing the nursing process. But now we're basically saying, no, that doesn't count for renewal. What counts is if you get the 20 hours. And that potentially has a large effect on the cost, because CEs can be very expensive. I mean, I don't know what the average rate for like a CE on a, you know, in an article, but I know going to conferences is very expensive.
Just to put it out there, for every like certification body, they offer free every month. There's historical once you Google on that. You don't even have to be a member to access those things. There is multiple websites out there. Hospitals also try to offer CEs, and some of their educations too come with CEs. So I personally, for all of my CEs for 2 certification, I've never paid $1 for any one of them.
Because I've seen that they offer CEs, but you have to pay in order to get the certificate of CE.
I've had the same experience, especially with some of the required ones for Oregon, like the cultural competency. They have the list of approved, and a lot of them are very expensive to take. I think I found one that I could sneak in that was free out of the whole list.
So I happen to be on that committee for OHA and approve those educational programs. But there is a list of programs that do count and are free. And then we also say on our website that you can determine that if you've had cultural competency within your health system, and that those hours can count towards that, and as well as students as they are learning their nursing curriculum for both cultural competency as well. So, so there absolutely are opportunities for nurses to obtain free CE, and we would be happy as we communicate this information to reference our nurses to those sites.
And I think that will be part of the plan to get set up, not only a standardized audit system, but also how we make sure there's a, I'd be interested to know what boards of nursing, since 93% of them are doing this, how they engage in this space, like where do they engage? Are we, you know, is that really our job? But even if it's not, how we do it. So that's a next step.
I was just going to say, personally, I believe that it's really, I like the practice hours component only because I think that there are so many different career paths, but at the root of it, the majority of us are clinicians. And so even with educators, if you just are 100% doing education, you remove yourself from that clinical component that you're teaching, and we just create more and more of a divide. So I've always appreciated the fact that we did have that part of our licensure in Oregon, just to keep people, I mean, I know that you can say document nursing care as like taking care of your parents, but just to keep everybody true to their roots, essentially.
And I appreciate that, but I, as a policy analyst, on behalf of the board, it's important for us to look at those national trends and look at what our statutory authority is. And based on review and recommendations from the public, it's an overwhelming majority that has asked us for continuing education.
Can I clarify, the 93% of jurisdictions require evidence of continued competence using CE? Is that's their only requirement, or is it either that or continuing or that or practice hours, or that and practice hours?
Let me clarify that one.
Thank you.
So Board Member McKinley Yoder, so I want to clarify this entire statistic. So 76% of boards require an evidence of continued competence. Of those 76%, 93% are using CE. So there are some boards that don't even require any evidence of continued competence. There are, once we get into the boards that do require some evidence, like I said, CE is predominantly the most common. We do see lots of different combinations. So sometimes it's entirely CE. I believe California is one of those states that is entirely CE based. We do see some states that it is a combination of CE and practice hours. There's also lumped in here states that give you options. So you could do CE, you could retake the NCLEX, you could do practice hours. And again, a lot of that is really rooted in what is the statutory authority of that jurisdiction to require.
What's the percentage of boards that require only CE?
76% of the boards that were surveyed.
No, I don't have the data of what percentage of boards only
Don't.
use CEP.
Okay.
Yeah, I don't have that.
I feel like that would be helpful to me because 93% only requiring CEs makes me go, okay, yeah, we're a real outlier. But if it's part,
3% of those that require anything, right? So then the other portion are people that just go, meh, just keep being a nurse.
require CE as part or in whole.
Pay the money, yeah, basically pay the money, pass go. But of those that require anything, 93% choose CEs.
No.
Okay, then I misunderstood it.
Required as part or whole.
You're saying,
Right. Yeah.
Right.
Yep. I think, again, like I said, the reason you see so much variability is what do the statutes allow in that jurisdiction?
And I think that's a key piece of the movement and the recommendation of the RAC and the policy analysts that support the board.
that I trust in all the work that has been done to this point, and that that I really feel that the CE, moving towards the CE, is really the better way to establish a minimum standard and make sure that it's in alignment with our statutory limits and the national trends. I think we've spent a while discussing this, and I think it would be good to move to a motion.
Okay, I have 3 different types of motions because we
Right.
do have some new language, so we're going to adopt those. We're going to modify some of the amendments, and then we're also going to repeal some sections because we consolidated some sections together, so there'll be 3 that, and please forgive me for all of these numbers. I would like to propose a motion that the board approves initiating the rulemaking process by providing notice and opportunity for public comment and holding an administrative rule hearing on the proposed adoptions of Division 31-0008, 0042, and 0043 as presented.
So moved.
I'm sorry, as modified, because of grammatical corrections.
Okay, so we're going to consider that one modified
We're
too?
going to consider that modified.
Okay, thank you. So moved.
Second.
It's been moved and seconded. We'll do a roll call vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder, nay. Joni Callis.
Nay.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Philippa Nesta.
Aye.
Rachel Mitzel.
Nay.
Motion is passed.
Our second motion, that the board approves initiating the rulemaking process by providing notice and opportunity for public comment and holding an administrative rule hearing on the proposed amendments of Division 31 in Title 006, 0039, 0041, 0048, 0051, 0055, 0085, 0086, and 0087 as modified.
So moved.
Second.
Didn't we need to add 0035, or did you? As well as 0052.
Okay, I'm going to read the numbers one more time to make sure that we get all the numbers. 0035 and
35 changes the statutory, it updates statutory authority, and I believe 52 does the same.
okay.
Yes.
We're going to give that another go. That the board approves initiating the rulemaking process by providing notice and opportunity for public comment and holding an administrative rule hearing and proposed amendments of Division 31, Title 006, 0039, 0041, 0048, 0035, 0051, 0052, 0055, 0085, 0086, and 0087 as modified.
So moved.
Second.
It's been moved and seconded. We'll do a roll call vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder, aye. Joni Callis.
No.
Linda Stanich. Aye. Oleniki Toobola. Rachel Dennis.
Aye.
Philippa Nesta.
Aye.
Rachel Mitchell. The motion is passed.
Third, for Division 31 here is that the board initiate the rulemaking process, approve the initiating of the rulemaking process by providing notice and opportunity for public comment and holding an administrative hearing, and propose repeal 0015, 0021, 0026, 0027, 0032, 0040, 0061, and 0065 as presented.
So moved.
Second.
Motion has been moved and seconded. We'll do a roll call vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toobola.
Aye.
Rachel Dennis.
Aye.
Philippa Nesta.
Aye.
Rachel Mitchell. The motion is passed.
I will be followed by my colleague Laura Blackhurst.
All right. I am moving us to Division 41, which operationalizes standards for licensure and function of the nurse intern. Related to House Bill 3044, we've updated the process for license application, renewal, and intern supervision to align with the changes to ORS Chapter 678. With the licensing process for an intern being simplified, we are also proposing a repeal of the rules related to license renewal that would no longer be needed because the nurse intern license could be issued to expire on the student's graduation date. And then additionally, within this division, we're updating some of the terminology to align with other areas of the Nurse Practice Act, notably Divisions 6 and 21, which were updated this past June. Those divisions had used new language around the clinical component and faculty supervision, and so we're updating language in Division 41 simply to be consistent throughout the Practice Act. And then finally, we have several proposed revisions that are just updating the statutory citations on the rules to reflect the current statutes. Happy to answer questions on this.
This might be a very silly question, and I admit because I said it in my head before. So when the nurse intern license is issued to the graduation date, how are we notified if the nurse intern drops out of school?
So there is a requirement in Division 41 that students notify us of changes in academic standing or enrollment, including like leaves of absence or dropping out of our program. And so that would already be covered.
Thank you.
I had one question about this. So it says that the nursing education program shall be approved by the Board of Nursing and then include a clinical component. So does the student have to have, so some programs they might enter when they're 18, have 2 years of prerequisite, have no nursing courses? Do they have to have begun the nursing courses in order to be in the nurse intern, to be like certified?
I think I understand your question, Board Member McKinley Yoder. And in our requirements for the nurse intern license, we do have to receive an education verification from the administrator at their nursing program. And so we'll be getting from their program the attestation that they're enrolled, that they've taken a clinical course, completed the clinical course. So that is part of the process. Yeah.
I turned it off. Oops, went the wrong way. Did we determine if the first one is as modified?
I believe we just had a spacing issue. So
Right.
it's not
You don't have to.
modified. Yeah.
Perfect.
Right. Otherwise, I'm happy to bring a motion. Right. I motion that the board approve initiating the rulemaking process by providing notice and opportunity for public comment and holding an administrative rule hearing on the proposed amendments to OAR 851, 041, 0000, 0010, 0020, and 0040 as presented.
So moved.
Second.
The motion has been moved and seconded. We will do a roll call vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder, aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Philippa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
Then I believe I have one additional motion. Here, I motion the board approves initiating the rulemaking process by providing notice and opportunity for public comment and holding an administrative rule hearing on the proposed repeal of OAR 851-041-0030 as presented.
So moved.
Second.
The motion has been moved and seconded. We'll do a roll call vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder, aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Philippa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion passes.
I believe I'm handing it back to Policy Analyst Cook.
Thank you, Policy Analyst Blackhurst. So our next proposed rules up for discussion is Division 45, Scope and Standards of Practice for the RN and LPN. So the proposed revisions you will find incorporate the new term healthcare provider. They clarify respective RN and LPN standards on assigning work to other practice team members, as well as make grammatical and rule citation corrections. I also respectfully want to point out the need for additional revision, and that is I missed one passage that still has the term health care provider in it that is used in a way that's not consistent with the new definition. So in your clean copy version, this is going to be on page 226. If you're looking at track changes, it's on page 245. And this one is under rule number 0050, and those are LPN scope and the practice of nursing standards. And this is section 2D, where it talks about prospective potential roles for LPNs, where it states that the LPN's clinically directed practice of nursing may occur in a role including participation in teaching of healthcare providers and prospective healthcare providers, and that needs to be changed to healthcare professionals and prospective healthcare professionals. I don't have the pages on my number. I just estimated.
No problem.
Okay. Can anybody grab that?
Yeah.
It's rule number 0050.
That one there was, in our copy, the formatting was off, so it can be a little bit hard to find the number 2.
Yeah, it's wrapped in one of.
If you read it in there, 2 is in there. It's in the one. There was, when they converted the PDF, it went a little wonky. That was part of our conversation this morning.
So has everyone found that yet? Okay. Are there any questions or further discussions for these proposed amendments? Are we ready for a motion? Happy to make a motion. Move that the board approve initiating rulemaking process by providing notice and opportunity for public comment and holding an administrative rule hearing on the proposed amendments to OAR 851-045, 0050, 0060, 0062, 0063, 0065, and 0070 as modified.
So moved.
Second.
Motion has been moved and seconded. We'll do a roll call vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder, aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Philippa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion passes.
Thank you. So the next set of proposed rule revisions is also mine, and that starts on page, I'm going to guess, 527 of your packet. So this is Division 49, and this is on contains standards on licensed nurse protocol utilization and development. So the proposed revisions to this rule replace the term licensed independent practitioner with healthcare provider in the standards on LPN protocol utilization. There's also been grammatical revisions made to accommodate use of the new term and to remove redundancy in the standards. We also put a modified the language a little bit in the purpose of the rules so that the term protocol is expressly described in that introductory area, so whereby we did not need to put the term or its definition in the Division 6 definitions chapter.
And will we be calling this as modified or not? There was an extra word.
Thank you. There is under, in the introductory, I think it's a rule number 00002. There's an extra letter A. So would that be as modified? Thank you. Okay. So are we ready for a motion? Excellent. So I propose that the board approves initiating rulemaking process by providing notice and opportunity for public comment and holding an administrative rule hearing on the proposed amendments to OIR 851-049, 0000, 0005, 0015, and 0020 as modified.
So moved.
Second.
The motion has been moved and seconded. We'll do a roll call vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder, aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion passes.
Thank you. And I will pass it back to Dr. Wickenhagen.
Mr. President, members of the board, if you would turn to page 266 of your packet for the associated motion, and there is only a track copy here, as we are asking to repeal Division 53 in its entirety. Of course, all of its content has been absorbed into Division 31 for the streamlining of the rules, reduces duplication, and no requirements were lost. They are simply reorganized. Any questions? All right. I would like to propose that the board approves initiating the rulemaking process by providing notice and opportunity for public comment and holding an administrative rule hearing on the proposed repeal of Chapter 851, Division 053 as presented.
So moved.
Second.
It's been moved and seconded. We'll do a roll call vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder, aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion passes.
Okay, we're going to now move to Division 55. This is in page 273 of your packet with the associated memos, clean and track changes. And what this covers for the chapter itself is the standards of practice around advanced practice nursing. The key changes that we have here are very similar in nature to other key changes that you've seen today of terminology and statutory alignment, definition of diagnose, clarified non-controlled substances for people to understand that that's what legend drugs are. So again, trying to remove barriers and make the Practice Act easier to understand for all users. And healthcare provider, again, was inserted. We also have helped with language around population focus to get that centralized. As you know, APRNs can have different foci, and we wanted to have consistent language throughout the Practice Act, and that has been changed to population focus. There's no substantive changes here to prescriptive authority or core practices of any APRNs. Ready for a motion? I would like to propose that the board approves initiating the rulemaking process by providing notice and opportunity for public comment and holding an administrative rule hearing on the proposed amendments to OAR 851-055, 0000, 0010, 0020, 0040, 0050, 0070, 0072, 0076, 0080, and 0090 as modified.
So moved.
Second.
The motion has been moved and seconded. We'll do a roll call vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder, aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
Okay. I am ready to present you with Division 62, which is the last presentation of these rule changes, of these 11 divisions. So this is the division around licensing for CNAs and CMAs. Again, many of the changes that you see here are consistent with the other changes that we've made recommendations in throughout the NPA. This impacts certified nursing assistants and medication aides. We've again focused on terminology cleanup and consolidation language here for the process. The core standards of CNAs and CMAs remain unchanged, and we believe that the changes here remove redundant steps and positively impact workforce stability, supporting retention and workforce strength. I do have a note to add 0061 rule. There is an error in sub 4 that has been pointed out to me, but of course I don't have that right in front of me. Oh, that's what it is. So we went through this entire division looking for the word reactivation, but there is the term reactivated in the end of the sentence, which I missed, which should be reinstated. So if the board agrees, we will modify that last line. All right. Ready for a motion? The board approves initiating the rulemaking process by providing notice and opportunity for public comment and holding an administrative rule hearing on the proposed amendments of Division 62, 0011, 0050, 0061, 0070, 0075, 0090, 0110, 0114, and 0116 as modified.
And can we add 0071?
And 0071.
So moved.
Second.
The motion has been moved and seconded. We're going to do a roll call vote. We're going to go reverse. So, Rachel Mitzel,
Yes.
Felipe Nesta,
Aye.
Rachel Dennis,
Aye.
sorry, Oleniki Tobola.
Aye.
I'm sorry, I just need to switch it up a little bit. Linda Stanich,
Aye.
Joni Kalis,
Aye.
Claire McKinley Yoder, aye. Margaret Hill,
Aye.
Marcus Cooksey.
Aye.
The motion passes.
One last motion.
Can I just remind ahead of time, it's
Yes.
0015, it's 0115
So this is
For the next
for the next one.
for the next rulemaking proposal here, that the board approves initiating the rulemaking process by providing notice and opportunity for public comment and holding an administrative hearing on the proposed repeals of Division 62, 0115, and 0072 as presented.
So moved.
Second.
The motion has been moved and seconded. We'll do a roll call vote. Rachel Mitzel,
Aye.
Felipe Nesta,
Aye.
Rachel Dennis,
Aye.
Oleniki Tobola,
Aye.
Linda Stanich,
Aye.
Joni Kalis,
Aye.
Claire McKinley Yoder, aye. Margaret Hill,
Aye.
Marcus Cooksey.
Aye.
The motion has passed.
We have the addendum.
Oh, but let me close out the presentation.
Yeah, well, we had a little like,
Yeah. Yeah.
you?
I'm gonna just bring us to the closing of this huge body of work, and discuss looking ahead. So pending today's approval to move to rule hearing, the next step will be the public comment period and rule hearing followed by board discussion and adoption in November and implementation on January 1, 2026. During these upcoming months, board staff will continue to work on updating internal processes, communicate changes broadly to partners, and provide technical assistance where needed. I'm very excited about what's happening at the Board of Nursing and look forward to the future of nursing in Oregon. And I will say that I think that we will have other boards of nursing looking to us on many things. When we surveyed the nation for things and seeing where there was so much lack of standardization and how we're really leading on that. I'm hopeful that we get through this and then potentially present and make recommendations for model rules and align with national standards where we were doing things out of the norm. So I just want to give a public appreciation to our policy analysts, our legislative director, our legal counsel for all the work, our administrative assistants who are going to be busy working with rule hearing, and all of you, because I know that was a lot, and it's the right thing for moving forward, Oregon. So thank you. Yeah. And Amanda, who's here virtually, was a huge part of it. Because she's not in person, I forgot, but I would be. And Philip Fox. Yes, we've all been in the war room. A little bit John Etherington. But yeah, thank you all. And we do have one more piece of the agenda, just one last thing. Do you want me to just go for it, or do we need a break?
Two more last things. Your addendum, and then I'd like just a brief
that's right.
minutes.
That's right.
Before we
that's right.
adjourn.
That's right. Okay. So can everybody move to page 781 in your board packet? A very large board packet. So you have not met Michelle Bell yet. She is Barbara Zhu's, she took on Barbara Zhu's role. She has started with us. She is fantastic and lovely. She just had a planned vacation this week. So I am coming forth to present on her behalf. But I respectfully request an extension of the survey and approval for 6 nursing assistant and 2 medication aid programs, which are due for reapproval surveys between September and November. And this is a similar motion I brought forth, Laura brought forth for herself when she took on the role and was new. That was approved. But the survey and survey reports may not be finalized and presented to the board for approval before each program's current approval period expires. Board staff are currently reviewing and revising our survey process and hope to avoid the need for future extensions and continuing approval. And I wanted you to know the impacted programs. And I did look into it to ensure there was no any problems on the horizon that we knew of. But that would be Avamere Health Services, the NA program, Tillamook Bay Community College, NA program, Clackamas Nursing Assistant Training, NA program, Belair Health NA program and MA program, Pacific Healthcare Training MA program, Caregiver Training Institute NA and MA program, and Portland Community College NA program. And I'm just respectfully requesting extension for the program approvals through the end of March 2026, giving Michelle Bell that 6 months to catch up, as well as Laura Blackhurst and Sarah Wickenhagen supporting her in getting up and running. Any questions, discussion? All right, well, board, I make a motion that the board approves an extension to the continuing approval of the nursing assistant and medication aid programs, Avamere Health Service NA, Tillamook Bay Community NA, Clackamas Nursing Assistant Training NA, Belair Health NA and MA, Pacific Healthcare Training MA, Caregiver Training Institute NA and MA, Portland Community College NA through March 2026.
So moved. Second.
Motion has been moved and seconded. We'll do a roll call vote. Rachel Mitzel.
Aye.
Felipa Nesta.
Aye.
Rachel Dennis.
Aye.
Oleniki Tuobola.
Aye.
Linda Stanich.
Aye.
Joni Callis.
Aye.
Claire McKinley Yoder. Aye. Margaret Hill.
Aye.
Marcus Cooksey.
Aye.
The motion has passed.
There's nothing else on the agenda other than what I...
Yeah, no, I don't have anything, and if I did, I don't think I'd be able to speak to it because my brain is...
Right?
So hopefully no.
Luckily...
That was yesterday when I had that question.
Yes.
All right, thank you. And luckily I wrote this out because otherwise I probably wouldn't be able to speak what is on my mind right now. Thank you for just an extra 3 minutes. As board president this year, I've been impressed with the diligent and thoughtful board staff working to maintain the integrity of our nursing practice. I truly appreciate each of your insights and endeavors. To my fellow board members, I saw it as my goal to encourage each of you to respectfully speak your truth, even if it feels lonely at times, so that we collectively may make the best decisions. Thank you for this opportunity to be your board president for this past year. With the upcoming November board meeting, I would like to remind the board of the annual election of a board president for 2026. I will be resigning from this board at the end of 2025 so that I may support my family through growth and challenges. No doubt this board has other board members that would make for an adept board president. You all will continue to have a wise and experienced leader in Director Prusak, and I look forward to working with y'all for the last time in November meeting.
Thank you, Mr. President. We will make sure that we find time to celebrate you at the end of our public board meeting in November. I know you hate it.
That's why we need to do it.
Yeah, exactly.
I'm sorry. Yeah, sometimes I make people do things they hate, so I'm the boss. No, no. I will speak many kind words at that time when my brain is thoughtful. Because right now, all I can think is thank you for your service and shining light on so many things and leading thoughtful conversations. But we'll talk more about that on your last day. And now it gives the board the opportunity to think through elections, and anybody can call me with thoughts about that. It's no end. Yes.
2 total.
I just feel like you have to stay. I barely know you. No,
I can tell you all about it. I can tell you all about it one-on-one, okay? The meeting is adjourned at 3:18 p.m.